Okay, well, welcome to Leicester City Council's Health Scrutiny Committee. My name is Patrick Kittrick. I am the chair of the Health Scrutiny Committee. Other members of the committee will introduce themselves under declarations of interest. Item number one, I've had one apology for absence from Councillor Paul Wesley. Has any other apologies been received? No, I'll take that as a no then. Declarations of interest. Members are asked to declare any interest they may have in the business on the agenda. So if I start with Councillor Fonseca, have you got any declarations of interest in tonight's meeting? If you just want to introduce yourself.
Yes, Chair. I'm Councillor Fonseca, and I have no declaration of interest.
Okay, Councillor Chamond.
Hi, good evening. Sorry, I was a bit late. No interest, please. Thank you.
Councillor March.
Evening, Chair. Hello, I'm Melissa March, and nothing to declare.
And Councillor Sangster.
Hi, I'm Deborah Sangster. I have no interest to declare.
Okay, thank you very much. Other people who contribute to the committee will introduce themselves when they speak on a particular item. Item number 3, minutes of the previous meeting. Have people got any questions about the accuracy of those minutes? No, are they agreed?
Yes.
I'll take that as agreed.
Yes.
Update on progress with matters considered at previous meetings. Just a couple of things by way of chair's announcements is there was a question from Sally Ruwan in follow-up to some of the questions about the hospital's plan. We've received an email. We can chase up those issues, but if Jason, we can have them read into the minutes and then chased up with the various people about details around the hospital plan. So that's been received formally. We'll read that into the record, and that will appear on the next minutes, as hopefully so will the answers to that. The other announcement, was very pleased to see the agreement for the sale of Hospital Close for 10.5 or 10.7 million pounds, which will bring 150 properties in by the NHS and Leicester City Council working together, beginning with passing over a big cheque and taking away a location badly in need of repair and renovation and regeneration. I think we can claim that for this scrutiny committee is where the idea originated from, so it's quite good to see it progress so rapidly. The only other thing I've got is at the last scrutiny committee meeting, we asked for some information on hospital readmission data. I don't know whether colleagues from UHL want to summarise that. I'll preface your feedback on it by saying it did show, certainly from the graphs that I saw, that there was a concerning amount of readmissions for people who've been discharged under COVID, and I appreciate that there was a lot of pressure to free up bed spaces, but just the question I would ask, having seen the figures, is to ask whether that's a cause for concern. As I said, it's not particularly helpful if people haven't seen the actual chart, but certainly from a lay reading, it did have some causes from concern that people were being discharged who were suffering from COVID-19 and then had to be readmitted. So if I can go over to UHL for the comments on that readmission data.
Thank you, Chair, and good evening, councillors. I'm flying solo at the moment. My other colleagues from UHL are struggling to get onto the meeting. So, Jason, if you wouldn't mind keeping in touch on that, please.
We can delay the item and come back.
No, I can speak to this. So, what the data essentially showed was that. I've got now 2 people joining me in my office trying to get online. What the data essentially showed was there are 2 lines in the graphs, and the first line showed non-COVID readmissions, and non-COVID readmissions have stayed broadly the same during the period of the pandemic over the last 12 months. But COVID readmissions have increased, and specifically at the two spikes of the pandemic. So the spike of wave 1 in April, around April the 14th, 2020, and then again, well, just a few weeks ago. So what we can definitely say about the data is readmissions are higher in terms of COVID positive patients than they are in non-COVID positive patients. Understanding the reasons for that is going to take an awful lot more work in terms of case note review, looking at multimorbidity, looking at age profiles. But speaking to one of our acute physicians a few days ago, and we're looking at this data, she thought that actually there was some kind of correlation between those peaks and the age of the people who were being readmitted. And her hypothesis, but it's nothing more than that, because it's not backed up with any deep dive into the data yet, is that for a cohort of patients who get COVID, recover from it, but who have other comorbidities or who are already frail, it increases their likelihood of being readmitted either within 7 days or within 30 days. So like much of the work that we've done on COVID over the last 12 months, some of it we think we're doing better, some of it has begged more questions than we're capable of answering whilst dealing with the pandemic itself. But it's something that we're returning to in terms of a deeper dive into what's going on. But I just want to assure councillors what isn't going on, in inverted commas, is we're kicking people out early with COVID. It seems that actually COVID just means that people are more likely to be readmitted post their COVID first admission. And that's as far as the data tells us at the moment.
Okay, just a quick follow-up question. Has this been seen in other hospital trusts, or is there, or have we not got that far in the data yet? Is it a Leicester phenomena, or is it something that we're finding across the NHS?
The only benchmarking that we have our hands on recently in terms of COVID outcomes is from an agency called Dr. Foster. And they have benchmarked across the 144 different acute trusts who have been fighting pandemic. And their benchmarking shows that actually Leicester is in the top 3 for COVID outcomes in terms of clinical outcomes for the, in layman's terms, the avoidance of death. So COVID has moved so quickly.
Okay.
As you'll probably know, that actually any further research that's got any kind of veracity to it won't be around for quite some months, if not years. But everything. Okay. Sorry, go on.
Just quickly, because it's a busy agenda. But the key thing is clearly we don't want readmission. We're trying to minimise readmissions of all types. When do you see potential actions being taken in order to avoid this readmission problem that we've got if COVID continues to be a feature of that?
Well, to be absolutely blunt, Chair, defining what the actions were would require us to understand what is causing this.
Yeah,
and we don't know that yet.
Okay, I mean, so when have you got a timeline of when we will?
No, I haven't. No.
Right. Okay. Can we just put that on the agenda then for an update until we've got a bit more clarity on that one? Okay. As I said, it's a busy old agenda, and at the end of the day, if you haven't got the answers, then me asking it repeatedly isn't going to generate an answer. So if we can keep a standing item on that whilst we monitor the outcomes of that. Okay, thank you very much for that, Mark. If there's no other updates on progress with matters considered at previous meetings, then I've already dealt with the chair's announcements. Petitions, I understand there are no petitions. Questions, representation, statements of case, I don't believe there are any, except with reference to Sally Ruan's follow-up email, which dealt with under matters arising from the minutes. If we then move on to the Director of Public Health, Ivan Brown, with his COVID-19 update, and actually if we take the COVID-19 update and the vaccinations update as one piece, that will probably be more efficient in terms of time. So Ivan, over to you.
Thank you very much. As he did such a good job last time, so I have brought Gurjit back to share the screen with us. So if Gurjit will just take us through the data, and then we will pick up the questions that's outside of that.
Okay, thank you, Ivan. I'll just start to share my screen now. Just let me know when that started to come through.
That's great, we can see it.
Yeah, it's just not quite in present mode, that's all. But I don't mind seeing your slides ahead of time if that's it. Yeah, that's fine, please.
Brilliant. Okay, so my name is Gurjit Rajania, and I'm one of the public health analysts here at Leicester City Council. Today, I'm just going to take you through some of the latest positive test data, data on admissions, COVID-19 mortality, and finally looking at the latest on vaccination data. Okay, so let's have a look at our positive results. So Leicester had its first confirmed case on 11th of March 2020, and there have been about 34,000 confirmed positive tests in the city up to the 26th of February 2020. Below, you can see two charts there. The first is positive tests by week. And you can see in those weeks of just following Christmas. So there's weeks of early January. We can see where we reached about 2,000 positive tests a week for around 3 weeks there. But since that period, we've steadily started to fall. And on our last week of data up to the 26th of February, there were 736 positive tests. Now, if we look at the moving 7-day moving average, we can see that we're averaging currently around about 95 positive tests a day. So let's have a look at the picture over the last 28 days. And you can see how this takes us from around the start of February, where we can see a slight fall and then a real steadying of positive tests. That yellow line is that moving average. And Leicester's kind of just reached a bit of a plateau. We're averaging around about 130 tests a day. But in recent days, it has started to come down. Of course, those figures in that red box are likely to rise as tests are confirmed in the labs, but hopefully by not too much. Okay, how is the rate looking? So currently the rate per 100,000 in Leicester is at 218, and this is currently amongst the highest in the country. Below we can see a chart. Leicester is the red line running through this chart, where we're comparing Leicester against the national picture, England, which is the purple line running through, and then some of our statistical neighbours, such as Birmingham, Bradford, Coventry, Luton and Nottingham.
I think that is a really useful chart to look at, because I mean, just for the exec. So if you notice that red line with Leicester, this issue about how flat it is and how slow it is for Leicester, we don't see those same peaks, but it just does seem to tail for a longer period. So just in relation to that dialogue, sorry to disturb you, Gurjit. I just thought that's a very useful slide for people to understand.
Yeah, certainly. Yeah, Leicester, I mean, when you see that dramatic Nottingham peak that they had, you know, so it kind of dates from September to around late February, and you can really see that dramatic peak in Nottingham and that dramatic quick decline. Leicester, on the other hand, has had few of those dramatic increases, but has been steadily generally at the top level, and at the moment we are highest amongst those comparators. Okay, so how are we looking in terms of the number of tests and also the percentage of those tests coming back positive? So this is over the last 28 days. And for the last 7-day period up to the 25th of February, there were about 9,000 tests and 9.5% of those came back positive. And over this whole period of this 28 days, we have been averaging around about 10,000 tests in that previous 7-day period. but you can see that positivity has come down. So from 13% in late January to 9.5% on the 25th of Feb. Okay, now how does the positive tests and the rate differ by age band in the city? Now here we have the Leicester positive test rates by these different age bands. You can see that the thick blue line running through, that's the Leicester overall. And then we have it split by different groups. That green line is the 0 to 17 rate, and that's consistently been lower than the Leicester overall and being the lowest of all age bands. Then we have the fluctuating 18 to 21-year-old line, and that's fluctuated as students have come into the city and then departed and that kind of thing. So you can see a real increase in around about late September, early October, but then it coming down again. The 60 plus, that's the yellow line running through, and earlier on it was below the Leicester overall, but following around Christmas, it started to follow that Leicester overall line and has fluctuated slightly in recent weeks. What's consistently been over the Leicester overall rate has been that working age band, that 22 to 59-year-old band. The rates for that group have consistently been higher than the Leicester overall rate that's run through here. And let's have a look how the picture currently looks by local area. Now this is data for the last 14 days up to the 26th of February. And we can see actually the city reporting the highest rate of tests per their population is Moacre and Stocking Farm. It's followed by Rushy Fields, St Matthews and St Peter's. You can see other MSOAs or local areas in the northwest also featuring high on this list. Abbey, Beaumont Leys, Castle Hill, all in the northwest of the city, and that's where we're seeing some of the highest numbers and rates of COVID-19 positivity at the moment. So very, very different to different times in the pandemic where we've seen a bit more of a concentration in areas to the east and the northeast. Okay, just moving on to admissions now. So we can really see the impact of this second wave here on UHL, and this is Leicester resident admissions to UHL, and it's been really high since about early November, and there were 5 consecutive weeks where COVID-19 admissions exceeded 100 following that Christmas period. In recent weeks, thankfully, the number of new weekly admissions has started to fall, and we had 59 admissions to Leicester resident admissions to UHL in the week up to the 26th. Currently, so this chart looks at the admissions minus those daily discharges for Leicester resident patients at UHL. You can see we did reach a high of around 222 Leicester residents at UHL with COVID-19, and that was in around late January. This has steadily fallen, and we're at about 90 Leicester residents currently at UHL with COVID-19. Okay, and let's have a look at mortality. And this here is showing deaths in Leicester during 2021. There have been 600 deaths in Leicester in 2021 so far, and that's all deaths up to the 19th of February. Based on average mortality in those pre-pandemic years of 2015 to 19, we would expect about 421 deaths for that period. So it reveals an excess of 179 deaths in Leicester so far in 2021. In 2020, we exceeded expected deaths by 412. As you look at the chart, you can see those deaths. We have a complete picture for January 2021, and you can see it far exceeds that kind of grey, that mortality range of what we would expect based on those years of 2015 to 19. Of course, and we can also see that yellow line running through that chart, that's deaths in 2020. And of course, the pandemic didn't start until until March, and you can really see that how in 2020 in March and April we exceeded expected deaths for those months, but then fell within the range over the summer months, but then began to exceed those expected deaths again in November and December. The following slide just looks at the weekly picture of mortality, of COVID mortality. Over the entire course of the pandemic, there have been 787 COVID-19 deaths in Leicester. About 731 of these are within 28 days of a positive test. And in recent weeks, we could see some really high figures of COVID-19 deaths, 53 in the weeks up to the 5th and 12th of February. The most recent week, we've seen 28 COVID-19 deaths. Okay. The following slide, this allows, I'm showing some age standardized mortality rates. Now this allows us to compare accurately between different areas. So for example, we know that England and Leicester have very different population and more importantly, very different age structure to its population. England has a proportionally a lot more of an older age profile compared to Leicester having a younger age profile. So these age standardized rates allow us to compare Leicester and England and different areas as if their population sizes and their population age structures were the same. So here we can see the rates and it dating back to April up to January, and we can see England in that purple line and Leicester, that red line running through this. We can see actually at the very start of the pandemic in April 2020, Leicester did not have the highest age standardized mortality rate for COVID-19. It was a lot lower than many of our comparators. But as we move through into the summer and as COVID-19 did linger on longer in the city, you can see that our COVID-19 mortality rate was higher than our comparators and the national level until around August, where we fell in line and we were at the lowest point in terms of rates, positive rates, admissions and mortality. You can see that starting to rise into September and moving it up into January, where Leicester are again fairly high there, amongst higher than the national and also higher than many of our comparators in terms of age standardized mortality. If we total up all of that data together from March 2020 to January 2021, so all of those COVID-19 deaths, we can see that Leicester, like many of our comparator cities, has a statistically higher COVID-19 mortality rate compared to the national, but we're similar, aren't we, to those authorities, Luton, Birmingham, Nottingham and Bradford. Okay, just moving on now to the vaccination data. Okay, and this is data up to the 21st of February, and it shows the percentage uptake for the under 70s and the 70 plus population. Of course, not all the under 70s have been invited, but it's just a percentage figure. So we can see here. So first we've got the national. So we can see about 20% of under 70s have had their dose 1 administered. That compares to Leicester, where it's around about 18%. When we look at the 70 plus population, we can see that about 96% of England's 70 plus population have had dose 1 administered, and it's closer to 91% for the Leicester 70 plus population. Now, how does this look across the city and by our local areas? Again, this is data up to the 21st of February, and we're using the GP registered population as that population denominator to calculate that uptake percentage. The table is sorted by the uptake amongst the 70 plus population. So you can see St. Matthew's and St. Peter's at the very top of that list with an estimated 70% of their 70 plus population having received dose 1. That's followed by Charnwood and Spinney Hill. Areas with a much higher uptake of dose 1 for their 70 plus population include South Knighton and Weston Park at the very bottom. some of the least deprived areas of the city. But of course, there are other less deprived areas who have also done fairly well in terms of vaccinating their 70 plus. As Monsell at 91%, and Braunston West and Saffron also with fairly high 70 plus uptake vaccinations. Now let's have a look at that mapped across the city. So we can see those kind of dark blue areas. That's where this percentage of the 70 plus population vaccinated exceeds 90%. The lighter blue is between 80 to 90% of 70 plus people residing in those areas have had dose 1 administered, and then you can see in those kind of pale orange areas in the city centre south, moving into Spinney Hills and St Matthews, St Peter's, moving along that green lane into Northfields, between 70 to 80% of their 70 plus population have had the dose 1 vaccine. Now we do have some ethnicity information as well. And we've got 2 charts here looking at the uptake of dose 1 by broad ethnic group here for the under 70s and the over 70s. Now, consistently across both charts, we can see that actually the white population and Leicester's white communities have had higher uptake rates for both under 70s and over 70s. And the non-white groups, Asian British and in particular Black British, have had lower uptake rates for both under 70s and the over 70s groups. And that's sort of how you can see that information in these charts here. I've also brought in just findings from a UHL study, which kind of corresponds with the findings that we're seeing. So this was a study of all healthcare workers at UHL, and it includes vaccination data up to the 3rd of February. And what was striking about this is the much lower uptake of vaccination amongst the non-white communities. So South Asian and Black British both having a lower percentage of healthcare workers vaccinated at 59 and 37%. But also there was a fair difference you can see here in deprivation. So those living in our least deprived areas was more likely to be vaccinated compared to those in our most deprived areas being less likely to be vaccinated. There's further COVID-19 data available on our website, and I've included links here, both to our website and our Leicester Open Data platform, and a link to the national tracker and national mapping of COVID-19 across the country. That's everything I wanted to take us through today. Thank you.
Thank you very much, Gurjit. That was very good. Well, it was alarming, but it was very informative. If you can bring us back to slide 15, and really, I think if we post that up, it's that's and you can put that up on the screen, because certainly when it's my areas of concern, that's really what I'm going to be focusing on. But quite happy if members of the committee want to indicate by raising the hand in order to ask any questions, or at this point, Andy from the clinical commissioning group, if you want to introduce yourself and see if you've got anything to add to Gurjit's presentation, and then Ivan to come back with any additional thoughts. Andy.
Yes, thank you, Chair. So good evening, everyone. My name is Andy Williams. I'm the Chief Exec of the CCG. We've got quite a lot of detail to go through with you. And I know I'm joined this evening by colleagues Caroline and Richard, who can talk in some detail about the way we've been working with the vaccination programme and trying to compensate for what we anticipated would be variability in the uptake. At this stage, I just wanted to make a couple of points, if I might, really. I think the first is to say that the vaccination programme has been rolled out on a kind of a wide offer basis. So the uptake rates clearly vary, but the offer rate doesn't. We've offered the vaccine consistently and uniformly across the city and across the areas. What we're seeing, of course, is that different communities, different geographies, different age groups have different uptake rates. We'd anticipated that to some extent, and we've done a lot of work on communications and trying particularly to engage those communities where we suspected there may not be as greater vaccine confidence as others, and we can talk at some length about that. And we've also been trying to work to get as detailed an understanding as we can about the reasons for vaccine hesitancy or a lack of vaccine confidence. Rather than make presumptions, we're actually trying to engage with the communities themselves and key leaders within them to get a real kind of sense of the sorts of obstacles that we need to overcome. And then in particular, we've got we can describe the existing approaches which we've used, and we can also talk about some of the things which we're now just starting to do in light of this further understanding of the uptake. I suppose the final thing to say, although I don't in any way want to diminish the significance of the variability, which I know, Chair, you'll want to explore and understand in more detail, it is worth saying, I think, that the vaccination picture generally across the city is more positive than we've seen from the vaccination program. So we've had a good vaccination program, relatively speaking, by comparison to previous years, for example, on influenza, and these vaccination uptake rates compare very positively to those. And we've also had some fantastic engagement with communities, with partners, and with others, which have characterized our vaccination efforts. So there are positives to pull out of this, but clearly considerable concern about the variability of uptake, which I know is the main thrust of this evening's conversation. So I'll leave my introductory remarks there, Chair. We've got quite a lot more detail, but very happy to open it up for questions and to get the discussion moving.
If members want to indicate by putting their hand up or putting something in the chat bar, I think I've got to come in quite early, and if we go back to the graphic that I originally asked us to look at number 15, I really do need to, as it were, set the terms of the debate, which is the vaccination programme has been fantastic. It's an amazing piece of public health medicine. It is brilliant, and the people who've done it are absolutely dedicated, and I know how hard the work is. But we have a problem, yeah, and I think we can't shy away from the problem. And the problem is, when you look at it, it's literally, there is an area of Leicester which is the wrong side of the tracks, yeah. You measure it by going down the mainline rail station, and pretty much with the exception of St Matthews, there's a whole swathe of the city to the east of the railway line where we've got vaccination rates which frankly aren't good enough. If we go back to slide 14, if we can call it back up, please. If we have a look at that, no, it doesn't appear that we're getting it back up. I'll take St Matthews and St Peter's, right? Currently, with the over 70s, we're at 70%. As we go down the age cohorts, yeah, that is not going to bring that figure up. If we track the sample of NHS staff, what we find is funnily enough, as you go down the ages, that vaccination take-up tends to fall. And that's intuitively, you get that. The younger people feel that they're not as vulnerable to the vaccine. There may well be unfounded concerns about fertility. It's going to come down. So what we're looking at and what we're staring down the barrel of a gun with this section that's in beige on the map is we've got 70% vaccine take up in St Peter's and St Matthews. As we go down the age groups, that will drop, and that may drop to as little as 50% or potentially even lower than the population. from everything I know as a layperson, 50% people taking up the vaccine does not give us herd immunity in that area. And then if we go back to the map of number 15, yeah, if we look at the size of that population that potentially will not have herd immunity, that is bad for the area in beige, yeah. It is bad for that area on the wrong side of the tracks. But let me be absolutely frank. If we do not get those vaccination rates up in that area, then the whole city doesn't have herd immunity, because we will have a substantial area that is under-vaccinated in which COVID-19 can persist. And if we look just beyond the beige area, we have much better vaccination rates, but still not the top vaccination rates. So I think the challenge, yeah, to yourselves is, having done an amazing job, yeah, and across the country, the delivery of the COVID vaccine has been like a super tanker delivering millions of litres of vaccine to people. But what it hasn't got the agility to deal with the area that we see in beige. Yeah. Now, what I'm looking for, and quite happy for you to come in as the first sweepers, is how do we get that agility?
Yeah.
And the challenges, and this is where I come to the recommendations, is where we innovate, and I've read, as everybody else has read, about GPs ringing people up, doing reassurance. That's brilliant, but how do we almost break the rigid rules and procedures around the national rollout in order to reach these communities, which isn't just about communication, but actually maybe about varying the way we deliver and how we deliver. So that's really my, it's a little bit elongated, but I had to set out right in the terms. I am going to give you a tough time about this, because if we come back in 3 months' time and that map is still looking like that, or potentially looking even worse, then we've got a real problem. So I just welcome yourself and your colleagues' response to that. And Ivan, please.
Thank you
As well.
So thank you. I think that sets out, Chair, the challenge really well. And we have got quite a lot of extra information, I think, to come, including some new things that we're doing. So it depends at what point you want me to bring Caroline in, but we have got some slides and some specific information. So I'll just make a general point and say two things. One is we aren't stopping trying to vaccinate the age groups by cohort that we've already done. So where, for example, we've got over 70s, we may be moving to other age groups, but we're still working with those groups. So they haven't missed the boat. They are absolutely still the subject of our targeted intervention. And the second thing is that we're now working, as we did to good effect before, actually, with an approach we're kind of calling hyperlocal. We're stopping the general vaccination program, we're carrying that on rather, but we're now augmenting it with very specifically targeted approaches to particular communities by ethnicity or by geography or both. And we're happy to describe that. And we think that is absolutely the heart of how we're going to turn some of those orange areas blue, if you like, by saying, right, we've tried the general offer, that's only produced a result this far. We now have some innovations, including personal contacts, mobile vaccination, pop-up vaccination, a whole range of things that we're going to try, where we deliver the vaccine in a very different way to particular communities that we hope will increase their vaccination rate. So would you like me to invite Caroline to talk about that now, Chair, or would you like to take the questions first? Or?
Yeah, just on the chat bar, which I don't think everybody's got access to, because Councillor Sangster's asked what new different approaches are being implemented given what's known about vaccination hesitancy. Councillor March has got some questions, but I think if we bring Caroline in at this stage, I think that would be helpful.
Great, thank you.
Evening, Councillor Kittrick and fellow other councillors. I do have a slide deck, but there's rather a lot of them, so I'm not sure whether or not you want me to go through them or whether you want me to give you the headlines.
Headlines, please.
Yeah, okay. So, so as Andy's just described, our approach to addressing the hesitancy in the populations that we've talked about and those areas of concern, St Matthews, Charnwood, Spinney Hill, Northfield, Crown Hills and St Saviour's. You'll notice there are some county areas in there as well, which is, we've obviously got to look at it across the patch, but we're focusing on the city here. The approach that we're taking is based on an evidence-based approach, and we've been heavily supported by public health in this. When we came last time, Councillor Kittrick, I didn't have the data to share with you because we just didn't have that. 4 weeks later, here we are with a much better data set that allows us to drill down into it. But we're focusing it on a threefold approach. We're looking at vaccine confidence, convenience of vaccination and complacency. So we're trying to do it in a structured way. And our approach to this is based on the NHS Race and Health Observatory COVID-19 working group work that is supporting areas to enable us to make sure that we're using the right mechanisms for the right populations. But I think the important thing to recognise for ourselves is that we've got so much local data as well. We've got so much local information that we've learnt throughout the last 12 months with COVID. So this is a system partnership approach. It's not just based on something that the national team tell us to do. So if I just quickly run through those three areas. So in terms of confidence, some of the things that are coming up here around efficacy of the vaccine, some of the issues around long-term impact, you know, how people are saying to us, how do we know when we've only got a few months worth of data that the long-term impact is not an issue? And that links to what you were saying about concerns about fertility and pregnancy. Still some confidence concerns around the safety of the vaccine, and but a bit of apathy thrown in there as well. So we're working with Together in Hope to look at that overarching hesitancy, and we've surveyed over 2,000 people to try and make it a local informed understanding of what's happening. Some of the things that we're doing to be able to try and address the confidence issue, and that is definitely getting some of our system leaders together, clinical and non-clinical, and Ivan and I have done a couple of things now where we've been answering the public's questions around confidence in vaccines. Working with the City Council, there's been 135,000 fact sheets issued across the city. There's been a myth-busting webinar that we reached out to over 3,000 people. Facebook Live event had 40,000 views in terms of a session that we did to try and improve confidence. And you'll be familiar with the more recent stuff around GPs ringing people. And out of those people that they've phoned, we've seen 69% of them taking up the vaccine, and some of them asking for more information. So that's really positive. It's a really small start, but it is focused on those areas.
Struggle to get on.
Sorry, can I just ask Rebecca? I think your microphone's on, and just can you our screen.
Thanks. We're working with the City Council to do some very specific care home focused approach as well. Confidence in care homes is mixed. There's confidence in terms of patient confidence, but also staff confidence. And we saw a particular issue with staff confidence focused quite a lot around the risks around pregnancy and fertility. And so some very focused work on care homes. In terms of the convenience aspects, we've got multiple city locations from the local vaccination sites, which are the GP sites, but also the vaccination centre was specifically put in Leicester City to support that. And of course, our 3 hospital hubs, or 3 of our 5 hospital hubs, are in the city as well. So it does allow us for having convenience in the city. But in addition to that, we're doing some mobile pop-ups where we've got more pharmacies coming online now, and mobile pop-ups going into specific areas, and our first one being St Matthews. We've been supporting with transport options, again working with the City Council to get people if they've got transport issues, and have had cohort specific groups for example, specific clinics for people with learning disabilities, and then also female only clinics if we've got concerns about any mixing of male and female. We've also vaccinated our faith leaders. Our faith leaders have been very, very supportive with us, and they've been really keen to go out and give the messages into their local communities that are specific and from them. We've been supporting them in terms of what those messages are. But having vaccinated those faith leaders, it does help us demonstrate the fact that people have confidence in the vaccine from their local communities. And then around complacency, you're absolutely right, Councillor Kitterick. As we go down the age groups, we know that the complacency and the lack of uptake is going to get bigger and bigger. So we're doing some focus groups, particularly with the younger age group, to try and anticipate what some of the issues may be for that cohort. So that we can put some measures in place rather than try and do it as a mop-up. We put the measures in place first so that we can encourage the younger people when it comes round to their turn to be able to do that. So we've got specific preemptive work as well as retrospective work that we're doing with the older age groups. We've got a group specifically focused on this. They're looking at the data on a twice, 3 times a week basis to make sure that if there are any changes to it, we can influence it. But as I said, it is a system-wide group to be able to get underneath what the data is telling us, to try and adjust what we need to do based on what our population is telling us from the focus groups that we've got in place.
Thank you very much, Caroline. I'll come back to you in a second, but I'll bring in Councillor March. Sorry, just to ask Ivan. Ivan, do you have anything to add at this point, or shall I bring in Councillor March?
Yeah, just one point really, just to make sure that we're not missing some points here, which is clearly the vaccination work is absolutely key, and I recognise all the work that we're doing. But just to say, certainly for some of the groups, I mean, there are some really good news stories in there, because I think the gap so far between our white community and our Asian community is less than we're seeing nationally, and we've got to do a lot of work around that. But I think it's incumbent on me also as a Director of Public Health to recognise that some of the challenges that we face are not purely down to vaccination, and we miss the point if we just think about vaccination alone. A lot of the feedback that we get when we're working with some of the Black community and other areas is one of general confidence in institutions, be it the NHS, be it the local authority, etc., to believe that their best interest is at heart. So I think there's work that we do that goes well beyond vaccination in terms of making sure that we build confidence that allows things like vaccination programs to be more successful in areas of deprivation and in areas where there's a greater ethnic mix. So I just want to make sure that that's also part of this discussion.
Okay, thank you very much, Ivan. Councillor March, some questions.
Thank you, Chair, and thank you to everyone for that. One of my really positive things that I love at the moment is knowing of people getting their vaccine. It's like the good news at the moment that I'm seeing. My question has really predominantly been answered by Caroline, but also Ivan was hitting on it there. And I think what I was trying to say was that it's clear that deprivation has driven some of the kind of the devastating spread that we've seen of the virus across the city, and we can't let, looking at the maps, it looks like some of and the data, for example, South Knighton being lower even than West Knighton springs out at me around relative areas of relative deprivation. So we can't let that deprivation also impact on immunity and the rollout of the vaccine. And so I'm really keen to see how some of those innovations that you outlined, like pop up and go taking the vaccine into communities and stuff works, because I think certainly we saw that hyper local stuff really working well with testing, for example. You know, this is, I guess, hopefully similar, and then just keen to keep up to date with how it's going, really, because yeah, please, thank you.
Thanks for that, Councillor March. It's Councillor Sangster. Do you want to come in?
Sorry about that. I was just trying to find my way through. There's two questions, and one I think Professor Brown has answered, but my experience and discussions with various people is that if public health know about African Caribbean, particularly African Caribbean propensity to mental ill health, to blood pressure, to prostate cancer and other diseases, and they haven't done anything specific to support those communities to address those issues, why now are we being targeted for support all of a sudden? Is it really about us, or is it about our proximity to other people who might get ill? So there's because many of our community individuals are working in the front line, so that's one of the questions. So how do we get over that? If you didn't bother about me before, why are you bothering about me now? Is a synopsis of that. And the second thing is, we know that the vaccine minister, there was 23.5 million for community champions, and the LCC, we bid it, but we weren't successful. So how is public health curating community champions, and how are you supporting that rollout of support, really? So that's my question. Thanks.
Do you want to come back, Ivan and others?
Thanks. Yes, please. So the first point, Councillor Sangster, I think that's really important, and I think that's what I was trying to allude to. And I feel that when we're now having these conversations, because we are having conversations, you know, we are going into communities where we're speaking to them, we're talking to groups. But I've got a premise that sits here, and I think that to be fair, you know, the conversations with Andy, who's joined me on some of them, and Caroline, which is, we talk about the vaccination. Okay, let's talk about that issue, but utilising this opportunity to have meaningful conversations to say, right, when this is all done and dusted, when we get this out the way, let's deal with that. But we need to talk about the other things that you are now talking about. We created forums, we created areas of conversation. We started to talk to different groups that we hadn't perhaps effectively talked to before. But if we stop when the vaccination is done, or when COVID, you know, hopefully is past, we will have done a disservice. And I don't think that's a road that we want to go down. So I think, to be fair, Councillor Sangster, that's the conversation that needs to continue and needs to go on. But I think what this has done has allowed us to focus our minds in how do we start to get into those groups much better. And outside of this, I can tell you the various groups and conversations that we're having, champions that we're developing.
I've been following your smoke really quite well. You get everywhere. But in terms of the community champions, what are we doing with that?
That's the one I want to talk about.
Yeah.
Right. So community champions was, you know, I go on saying it was extremely frustrating. This wasn't something that we could bid into. They produced some kind of algorithm to determine who the 60 places would be. And Leicester were not picked out in that 60. Subsequently, we made contact with the department responsible for that to ask for a clarification as to why. We had 2 meetings with them, including with the data team who pulled together those algorithms, and the response, I don't think, was particularly satisfactory, which is the line has to drop somewhere, and Leicester kind of dropped outside that line. Lots of things to say that they're happy to work with us. But in the meantime, I've had conversations with the CCG, with Azar Faruqi, and we're just going to we're going to dig into our own pockets and find some money to do it. That's what we're just going to do. We're going to just do it. So started having conversations, certainly in St. Matthews. I was talking to a great group of Somalian doctors and medics, etc., last night about how we might be able to get this up and going, getting information from Birmingham and London who have had. So we're hoping to have that up and going within a matter of days, weeks.
Okay. There's some other questions around it which we've got from Councillor March, which I'll come to in a second, because I'm trying to get focused on this debate, and I get what you're saying, Ivan, and I get what you're saying, Deborah, about, in many senses, actually, if you look at flu vaccinations, it's exactly what you're talking about. Leicester City underperformed for years and years and years and years on flu vaccinations. And to a certain extent, when it comes to COVID, we're on an inheritance of a population that was never used to getting flu vaccinations, because it was always a bit of a Cinderella one. Why is COVID being there? I know you know the answer, Deborah. It's because other people can catch COVID from people. If it was prostate cancer, if it was mental ill health, which isn't transmissible, that's why it's transmissible. But it still leaves me with the issue of COVID in itself, and looking at it in the acute sense. And my challenge is that, and I get all these innovations, but let me just, in order to test how much latitude you've got in your behaviour, let me just pitch an idea to you. Bloke stood at the bus stop, idea, but I just want to test how much latitude you've got in approach. So one of the great areas where we do vaccinations, particularly with extended families, is family vaccinations, vaccinating in family cohorts. Chickenpox parties, measles parties, it's a way that people get together and they administer a kind of a weird vaccination process. So say you've got an extended family, so Granny Smith is called down, and then her son Jimmy Smith is in another cohort, and then Mrs. Smith might be down on a later thing, and then the kids and the grandkids are done later. So here's a challenge. Well, we know that in these areas there's extended families. So if tomorrow we found out in an experiment that this was a really good way of delivering it, would the national NHS rules on delivery, would we run into that, or do we have that latitude? I might be pitching the idea in itself, but I'm more pitching the idea into a sense of, whilst we have all this good acute innovation, whether we're still bound by national rules which are stopping us from pretty much throwing everything in the kitchen sink at trying to get these vaccination rates up. I get, Ivan, the issues about the long-term stuff, but I don't want that thing about long-term work that we need to do to almost be a way of not really tightly focusing down on this really immediate problem that we've got with low vaccination rates. Andy.
I can just come in on that. I think it's a really good point, and we have, for exactly that reason, petitioned. I personally have, and I know we have petitioned very hard nationally to allow us greater flexibility. Ivan, I know, has taken that to central government, to ministers, and actually so have I. As things stand at the moment, we don't have the latitude to do that. But the situation is changing and it's loosening. So I have some hope that we might get more discretion. As things stand at the moment, we are still being asked to ensure that we vaccinate in accordance with a national cohort in groups. But part of the reason we're doing the research that we are is to continue to build the evidence base. And I think what I would say is this, really. I think over the next few weeks, as we start to move this offer to the complete population, and we start to see virtually double the number of vaccinations being delivered across LLR, if we are still seeing, and we very well may be still seeing, marked differences in uptake, and we can pinpoint them to things like whole family vaccination, then I think we can make that case even more strongly and continue to lobby for it. So as it stands right now, we don't have the discretion to do that, but we are pushing all the time to get more flexibility. And there are some things we can do, so we can now get more mobile. The AstraZeneca vaccine in particular allows that. We don't have to stick to the very strict criteria that we had initially around which sites can vaccinate. We can get on the road, we can go house to house, we can go mobile, we can use pop-up. So all of those things will help. We can't just at the moment break out of the cohort groupings, but we might be able to in the future, hopefully. And certainly as we start to learn the lesson for vaccinating going forward, because this isn't going to be a one-off event, we will have a program of ongoing vaccination, then I think that program needs to learn the lessons that we've been picking up from the work we've done so far. So it's not the answer you were looking for, Chair. I don't think
it certainly isn't the answer I was looking for. No, and please, in the sense that yourself and Caroline are the bearer of bad news, in that sense, it's almost flipping what Ivan and Deborah were saying on their heads. You can imagine that if this problem of take up seemed to affect, let's call it frankly, if this problem of vaccine update affected more wealthier communities, you'd be damn sure that innovation and latitude would be applied. To a certain extent, because the low uptake is in the wrong side of the tracks, we're happy to wait a few weeks, a few months, and see how it goes. I needn't need to have a crystal ball. I think it was Einstein. If it wasn't Einstein, it was somebody else who said madness is doing the same thing and expecting the outcome to change. Our approach to vaccinations is not changing in that area. And I have to say, Andy, Caroline, Ivan, it's heroic how you are trying to make this work in areas where it's just not working, without being given the tools and the latitude to try different approaches. And it seems to be the wrong way round. We seem to be trying to build an evidence base when the NHS staff survey, when the initial data is telling us it's not working. Not for the vast majority of people, but this relatively small geographic unit. And for the life of me, I can't see why we can't just do different innovative approaches and see what works. Because I think because and I'll make this point, and my apologies to everybody, I am on a bit of a rant because I am finding this intensely frustrating. Because do you know what organism tries different approaches, and sees what works, and when something works, it's replicated and replicated and replicated, you know what it is. It's a virus, A virus does not sit there and consider the empirical evidence and then do a design paper. It tries different things, and what it finds successful, it innovates and it reproduces ruthlessly, If we want to beat a virus, we've got to act like a virus in this sense. And we've got to try different approaches in those communities, And I appreciate, Andy, you're a civil servant, Ivan's a civil servant, Caroline's a civil servant. But if there is one message from this committee, and I'll stop ranting in a minute, is that we have to have the message through that you have to be given the latitude to try all of the approaches. And the lesson, and the thing is, Ivan, the thing you are looking for, which is what is the long-term legacy, is when we find which approaches work and how we reach out into different communities, those can then be used across a whole range of other public health interventions. So we have got a window. We've got a window to put pressure on government to say, give us the chance to find out what works. Yeah. And if we find that, then we really will have got something good out of this. My apologies. I'll get my soapbox.
You know from our previous conversations, Chair, that I understand and agree with that sentiment. The one thing I would say, and I'm not trying to be an apologist here for national policy, but just to kind of put a counterpoint, because I think it is important. Yeah, this isn't entirely without rationale. This isn't a kind of jobs-worthy thing meets real world. That the reason it was structured in this way, and there was a really powerful evidence base, was that the initial supplies of vaccine, because it's being rolled out in just-in-time basis, as it's made, it's rolled out. We haven't built up a big buffer stock. The calculations done nationally showed that as the vaccine became available, targeting it strictly in accordance with the national guidance actually produced the greatest health benefit for the population of the country as a whole, and it was done as a national program. Now that doesn't in any way, I'm not disagreeing with anything you've said, because I think Ivan and I and others have argued very strongly and continue to for more local discretion, but I wouldn't want you to I wouldn't want to create the impression for this meeting that there wasn't a rationale for the way it's been done. There was. I think what we're now saying is we get all that, we've done the initial priority groups. It obviously has left some communities disadvantaged, and we can see the evidence of that very clearly in Leicester. Now is the time, or in the near future, is the time to kind of loosen up the system a bit and allow us a more flexible approach. And we absolutely agree with that. But I think all of us, and certainly clinical colleagues, did understand, I think, why we started the programme the way we did as a national programme. I think that was the right thing to do, but increasingly it would be helpful, I think, to have a little bit more wiggle room, to kind of get things right for us locally. So hopefully it's a kind of both and, not either or.
You will not find me disagreeing with you, Andy. In terms of the delivery of the mass programme. It works in Knighton. It works in areas that you wouldn't intuitively say it works. It works in Ersmonsell. It works in Saffron. It works in areas which you'd say that there are deprivation issues. Looking at the map, it works in parts of Braunston. It does work, and I see it as the big solution for the country, and I absolutely get it. But the issue is, and we speak as Leicester Scrutiny Committee, so we have to look at Leicester.
Of course, absolutely.
It does not work for a significant chunk of Leicester. And the bad news is the chunk is so big, it is dreadful for the people who will be affected by that directly, but it doesn't work for the city, because when you look at that map, that area is way too big, which will effectively, if all of our knowledge bears out, will not have herd immunity. And that's a big problem for us as a city. In a sense, if I'm going to go back to medical analogies, it's fine if you're going to try and do certain operations to use a great big saw, but sometimes you need to get out the scalpel. And that's what we're asking for. I'm not asking for the whole path of the NHS vaccination programme to be diverted. I'm just asking, in this area, I mean, even if you just focused on St Matthew's and St Peter's alone, you're talking a population head of 10 to 15,000, in order to try and find and do that innovation. This is not going to put us off track, and certainly, and I would like it to put it down as a recommendation. If people can remind us, this is, and to be frank, it may well be the only recommendation, because I want to give it the weight that it deserves. That there is the strongest call that this scrutiny committee can make for that latitude to be delegated in these areas of concern indicated there, specifically St Matthew's and St Peter's, because I think geographically it's a small area. It's an area where intuitively you would think that the location problems aren't there. St Peter's Health Centre is a hub. The People Centre is on the doorstep of St Matthew's, and that doesn't appear to be shifting it. So I think if we can crack it and find the lessons in St Matthew's and St Peter's, it's a case of we can certainly apply those lessons across. And you're talking not about a huge diversion of resources, but certainly learning some lessons. And if we can learn those lessons, it's not just Leicester that this will have an impact on. There must be areas across the country that have a similar issue. And can I just ask, just on a more prosaic question, with vaccine hesitancy, do we have any sense, to use what sounds like some statistical economic jargon, the propensity not to have a vaccine? Yeah. So, I will take, Jimmy Jones. Yeah. And Jimmy Jones says, I don't really want the vaccine. Have we got any sense of how badly he doesn't want it? Will he have it if somebody turns up? Is he what you'd call 10% hesitant, where actually he doesn't want to have the vaccine because he can't be bothered going down to work? And is there any sense where on the scale is that some people are, say, only 10% hesitant, but some people, say, for instance, somebody worries about fertility issues, they are 80% hesitant, and really no matter what we do, they're not having it? Have we got any feel for that range of hesitancy at all? I'm just interested.
I think the research that we're conducting is designed to help us answer that question. So I think we'd struggle to quantify it in quite the way that you've put it to us at the moment, Chair. But part of the reason we're doing the more detailed work and not simply making presumptions is that we want to get exactly into that space. Is it simply that we need to be more proactive in taking the vaccine to people? Is it that they simply don't understand? Or is it a fundamental philosophical objection that we won't overcome and we need to think about working very differently indeed? And we're trying to get that now, and we're getting more information all the time. But I think, honestly, we would struggle to give you a kind of a meaningful analysis in those. It's a good question, and we're doing the work for that reason, but I don't think we've got the answers to it just yet.
Andy, as long as it's part of the work stream, because clearly knowing where somebody is on the spectrum of, from fanatical anti-vaxxer through to somebody who says, listen, if you can give, I'm not being funny, it's the thing of somebody, you will find people who say, listen, mate, if you can give me the jab in the next 5 minutes, I'll have it. But if I'm trolling down to the health centre, just go away. So if that's part of the work stream.
It is, absolutely.
Okay, just slightly related to that, and it has been raised by the city mayor as well, the issue about spare capacity at vaccination centres. Councillor March asked specifically about whether teaching staff and/or police or other frontline workers could use that spare capacity. What's our understanding of spare capacity and the way that we can use it?
You want me to answer this, Andy?
Yes, Caroline, go for it.
So it's back to that latitude, Councillor Kittrick. Spare capacity is absolutely intended to be used for the cohorts that we're working through at the moment. So the message from NHS England, the message that we've given to our vaccinators, is that if they could have lists of people who they know that they could potentially call on, as we open the cohorts up, that's going to get easier and easier. So trying to call people in, but as soon as we can get some more latitude on the way that we use the vaccines, we will absolutely push at that door, because spare vaccines is definitely something that we're hearing every day, what's happening with that. But again, it's back to the fact that we're in a national programme, and the team are very, very clear that we have to stay within the cohorts.
We have very low vaccine wastage, to be clear. So this isn't about vaccine going unused, and we've been doing absolutely everything to minimise vaccine wastage, very, very low. So that's good news, and I think that's an important thing just to kind of add.
Is there an idea, before I come into Councillor Sanchez, is there an idea of how much capacity there is? I mean, I appreciate that vaccine wastage but how much faster could we go? How much capacity are we dropping every day on average?
Councillor Kittredge, Andy mentioned earlier that we're on a kind of a just-in-time model. So as we have enough capacity to deliver the vaccines that were issued. So at the moment, some of that capacity isn't in use because we know that we've got a reduced amount of supply across the whole country. But we also know that in 2 weeks' time, from the 15th of March, that capacity is intended, the numbers of vaccines coming into the system increases tremendously, and we are matching our capacity to meet that. And so, and that will coincide with additional cohorts being open to make sure that we've got the people coming through as much as we've got the vaccine coming in.
Okay, thank you. Councillor Sangster.
It relates to what Ivan was saying previously, and I just kind of want to tie him down a little bit. We know now that there's going to be a lifting of lockdown and COVID's nearly over. So in light of that, what are we doing to make sure that the report that identified minority ethnic communities were poorly served in terms of COVID responses and other health issues? What are we doing to make sure that we are prepared for the future and making things better? How are we preparing to build back better is my question.
Yes, thanks, Councillor Sangster. So yeah, the report that we brought some time trying to allude to when I was talking about the conversations that we're having right now, it's really, we've started that journey of engaging with communities. And have made commitments to working with communities as well. And I think that that's going to be our starting point. Yes, we're doing research. Yes, we're finding out more, but actually we're starting by talking to people and saying, and we've made some commitments around working around cardiovascular, working around drugs and alcohol. So, you know, there's some areas that we've already started to work with our communities on, and we're going to continue to do that. But quite happy for us to build something a bit more structured to bring back here, Councillor Sangster.
That would be really helpful. Thank you. So we can tie you down. That's you're bringing back a report about what it is you're going to be doing, and we can question you on that.
Yeah. Okay.
Thank you.
Okay. Is there any other questions before I move to the recommendations under this item? My apologies. I mean, there are issues such as the flare up in the northwest of the city, and I wouldn't wish anybody to think that we weren't looking at that. But it is a case of for the acute crisis, vaccinations are the way out. But and we are doing what we do with flare ups and we've done before. But this vaccination issue, I think, does merit the amount of time we spent on it. I think the key recommendation is, and I think we put it in the strongest terms, that we ask for latitude to experiment and innovate as quickly as possible, and do it on a basis of what Franklin Roosevelt called bold, persistent innovation. That government should be trying different things, and in this crisis that we look at the area of concern, the areas where we've clearly identified a lack of people taking up vaccinations, and that we ask for the clinical commissioning group, the NHS and the City Council to be given the latitude to try different approaches as a matter of urgency, so we're not back here in 2 months' time. And that we communicate that through the usual channels that Ivan and Andy and Caroline will advise us through, but we also take that up through our members of Parliament, that they put pressure in terms of this, because if we don't get this right, we'll be back here discussing this same problem. I think to take on board, so that's the main recommendation. As it were, the sub-recommendations of it is that the lessons of it, that should we be given this innovation, and people are already beginning to innovate within the straitjacket that we've got around the national rules, that we should have a report back to see how those innovations would help in future, dealing with future health issues in communities that have not been engaged with as much as they should, and that the long-term lessons of that community engagement be learned from this. And finally, I would ask, and I will ask for advice on this, that a regular update outside of this scrutiny committee cycle is given on vaccine updates along the lines of what we saw under slide 14 and slide 15, and in the same ways that we update infection rates, that we update vaccination rates in a similar fashion. Would weekly be feasible, Ivan, on that one? In terms of the updates to that slide that we've seen on 14 and 15, so we can see how the patterns are emerging. Because I'm just a bit scared of saying, well, we'll just leave it to the next scrutiny committee meeting. And I think the situation needs to be addressed on a more dynamic basis.
I see that Gurjit's come off mute for this one, so he's probably going to say something to make sure that I don't overpromise. So, Gurjit, what can we do that's manageable and sensible?
Well, certainly, I think last Friday was the first week that they released that lower area information, and they've promised to do that weekly. So as long as that continues, we can update weekly.
Excellent. Thank you very much. That's all I can ask for. Councillor Chammond, you indicated you wish to speak.
Yes, thank you very much, Chair. I think this question is for Ivan. Looking at the chart and the figures which was showed in the meeting today, there was a circulation about the coronavirus statistics. Is that true, or is that just randomly somebody has been playing around?
So
it was about Leicester and Leicester East.
About the statistics?
I think, yeah. Councillor Chammond, you might have to give a little bit more detail.
I've just got the chart and which gives the vote names and the figures of January, February the 9th and February 12th.
Where did you get that? What, from the...
Somebody has sent me on the WhatsApp.
All right, yes. Now WhatsApp can be a blessing and a curse. Councillor Chammond, unless you can share that with us on screen, probably best to take it outside of the meeting, because unless Ivan's looking at what you're looking at.
I think this has been sent to Peter by Councillor Solanki from the ward.
Okay. Ivan, I can just ask you quickly, have you seen it? And if you haven't seen it, the great thing about WhatsApp is I'm sure Councillor Chammond could send it to you.
Yeah, right. Then I will send it to you.
Yeah, okay. If you could do that, I'll send you an email now so that you've got my number, okay. And then I can respond to you directly.
All right. Okay. Thank you.
And can I encourage everybody that if like Councillor Chammond, I think it's very good of you, Padmina, that if people do receive stuff via WhatsApp, that they've got questions about it, then maybe not send it directly to Ivan, but certainly send it through to Public Health, because we've really got to keep a track of what's going on WhatsApp. Because I've noticed on a communication strategy, people were saying how the Radio 4 Today programme turned up at the People Centre. Well, you know, I'm hazarding a guess that the amount of people who listen to the Radio 4 Today programme on the St Matthew's estate is not particularly high, but WhatsApp use is. So if anybody has any intelligence that what's coming through on WhatsApp, particularly any messages that they're concerned about, please feel free, use our fantastic people at Committee Services. They're not going to thank me for it, but I'm sure if we can screen them through Cal and Cecida to try and get a handle on it, particularly if the message is concerning about WhatsApp, because we do need to respond to anything, particularly any information on there. So just to summarise, so we are looking to make the strongest of appeals for latitude of approach in areas of low vaccination, that we ask for the lessons learnt from that innovation to apply into longer term non-infectious conditions and infectious conditions such as flu, and into parts of longer term work for communities who we do not engage with as much as we should. And we've been given an indication from Gurjit, qualified by, dependent upon the data that we receive, that the data as presented on slide 14 and 15 will be presented on a weekly basis. So we can see whether Andy and Caroline's and Ivan's and all the CCGs, NHS and City Councils innovations, whether they're working or not. Thank you very much. Is there, and Carl says he's happy for people to WhatsApp him. I'm sure it's only with COVID related stuff. So if there's nothing else on that one, then we will move on to UHL audit update. So if I can ask Rebecca Brown and her team from UHL to give us a brief introduction to this, and then open up to members for questions. Rebecca.
Thank you, Chair. If it's okay, just if I introduce who the people are here. So it's myself as Acting Chief Executive, Mark Whiteman, who you know, Director of Strategy and Communications, but also Jonathan Shooter, who is our Deputy Chief Finance Officer. And he will take the technical questions, and Mark and I will just do a bit of a double act, if that's okay, Chair. So I think it is important, because of the context of this very, very challenging situation. I think it's important that we do a little bit of the background, if that's okay, Chair, and also then talk about really on the recovery and what we're doing around that recovery. But firstly, I want to say on behalf of all of the board, we all take this extremely seriously. The trust internally is under a thing called financial special measures, which is sort of the most severe situation that you can be in this sort of when something goes wrong as big as this. It means that we are very, very highly regulated. We have weekly and sometimes daily meetings with our regulators. We have a finance improvement director that sits alongside Simon and Jonathan, so checking everything that we're doing. And he brings with him, or she brings with them, a number of people also to really continuously not just look and support and guide us to recovery, but also to make sure that we're fit and able to be recovered. And that process has started 6 months ago. And so we've actually, even though this is in the public domain only in the last few months, it is something we have been working tirelessly behind the scenes to make sure that we can build the confidence back from in our community and with our partners. So I'm just going to hand you over very briefly to Mark, who will just talk to you about just how we got to where we are, and then I'll just come in with what we're doing about it.
Thank you, Rebecca, and good evening once again, councillor colleagues. I mean, I'll take the papers I've read, but just try and hit the high, or in this case, really the low notes. But it is essentially, back in the audit for 2018-19, we were given a unqualified audit by our external auditors. Unqualified essentially means clean, in other words, a reasonable audit. But actually at the time, the external auditors raised some issues that, though they were under what's called the materiality kind of line, in other words, on £1 billion worth of turnover, they didn't add up to more than £16 million worth of queries. They were sufficient to cause anxiety to the external auditor. and also sufficient to cause anxiety to the then chair of audit. So in the timeline at Appendix 1 on the paper, it shows what happened as a consequence of that, which was essentially the then Chief Financial Officer of the Trust was asked by our independent chair of audit, our non-exec director who was chairing audit, to respond to these questions that the external auditor raised and come back and report back. And that never happened. So eventually that was in October 2019, that was escalated up to the then chief executive. Some of you will remember John from previous scrutinies, and also to the then chair, Karamjit, and they asked our new chief financial officer, who was acting at the time, to do essentially a drains up, dig behind the scenes and try and work out what was going on. So Simon Lazarus, aptly named in this case, did just that. And I've got to say what Simon found wasn't pretty. And eventually that led to us having to make essentially what's called a prior year adjustment to the previous year's accounts, which essentially meant that the previous year's accounts had been misstated to the tune of somewhere in the region of £46 million. So that in itself was bad enough, and we briefed stakeholders, including Scrutiny, both here in County and Rutland, and other stakeholders back in January of last year on this. But Simon and the new finance team's work didn't stop there. They kept going down into the detail of our accounts, as did the external auditor, in preparation for the 2019-2020 accounts. And the more they looked, the more they found, and culminated essentially in a decision taken by the trust board in Christmas time of the year just past, to say, actually, we can't sign off our annual report and accounts this year because we can't vouchsafe that they are true and fair. And to be frank with you, that's an extraordinary position for any body to be in, any public sector body certainly to be in, which we absolutely understand. And the consequences of that, I think, are known. And if they're not, then they're written on the appendix in terms of essentially some of the changes to the board that have been made, and also what the impact has been on those of us who are here trying to sort out the technical phrase, the mess that's been left behind. So that's a really, I'm not a financier, as you know, and that's part of the reason why I think Rebecca's asked me to explain it rather than go into deep financial details. But my colleague Jonathan is all over the details on this, and I'm sure he'd be very happy to take any questions on it. I'd just leave you with saying, actually, at the moment, our job, linked to the two previous conversations you've just had around vaccinations, around inequity in health and access to vaccinations and access to healthcare per se, we've got two jobs essentially at the moment. One job is the same as every other acute trust up and down the country, which is to restore its services as we start to come out of the teeth of the pandemic. The other job is to restore our finances as we start to come out of this horrible year in financial terms. I'll leave it there, mate.
Thanks, Mark. So if I could just very quickly just give you the committee just an update on what we've done today, to then open it up for questions, Chair. So I think that important point around the change in the board, I think that is a very important point. And of course, last week we heard the news of our chair, a man who has done 50 years worth of public service, 7 years of amazing service for Leicester, recognising that it was also time for him to resign, and that he made that decision last week. But we have lost over a third. So every chair or any senior position around the financial decision making or scrutiny of UHL have all left UHL, and there are all new people in place. We have 2 additional accountants on the board in associate NED form. We have an exemplary high level, very, very experienced accountant in public. He's done a huge amount of work in public services over the years, Mike Williams, who is our audit chair, and he has been a fantastic, great advisor for all of us. And of course, we will have further changes as we go forward with the new appointment of the acting chief executive, the new chief executive, once we're out to advert, which will be sometime in the spring this year. The key focus of our recovery, and I use that word very importantly, is around the governance, the training and development of our team, making sure that we've got people fit for purpose, making sure that our reporting processes are strong, that we've got good grip and control, and we've got good training programs in place. And those training programs and development programs are from board level, so all the new people in the board together at the board, working all the way down to every budget holder in the trust. We are 6 months down this journey, and we've made some improvements, and we are seeing our financial run rate improve. This year we are sitting with a surplus. We will end this year with a surplus financial position, but remember that we still have a very large underlying deficit, but we have a plan put together for next year to reduce that, and we're working on that next piece of work, which is that system piece, is around a 3 to 4 year plan where we will get UHL and the whole of the NHS system into a non-deficit situation. I will stop there, Chair, but of course we'll answer any questions that people have.
Thank you very much, Rebecca. I will preface this, although I'm sure the committee will already take note, but I'll say it just so it's on the record. The point of the questioning about this is not to discuss individuals. There will always be individuals who will try and subvert systems either by design or by accident. But what we should have is robust systems and cultures that prevent such things happening. If an individual can overturn a system, then the system is clearly lacking. And if an individual or individuals can subvert a system to this extent, there are questions to be asked about the culture within the organisation. So if I can kind of direct, although I'm sure I don't need to look at systems and cultures and how they are going to be turned around, I think that would probably be a fruitful way of taking some lessons from this deeply concerning event. So I'll go, if you want to add, and then I'll bring in Councillor March and Councillor Sangster.
Yeah, I was just going to add, Chair, that actually that culture piece is absolutely the next, this is where we need to really focus ourselves in the next 6 months. So in some respects, the first 6 months of our recovery, it is somewhat easier because you're putting in place all the processes that you should have had, the policies that you should have had, making sure training has taken place. But actually it's that change of culture that will really make a difference. And that is the key programme going forward. So again, we'll be open to any suggestions or areas of focus that people could support us on that.
Thank you very much, Rebecca. Councillor March and then Councillor Sangster.
Thank you. I hear what you're saying and completely recognise the scale of the challenge, given there are still going to continue to be, sadly, pressures on budgets and the plans for the future hospital reconfiguration. We're still not through the pandemic and all these daily meetings that you've had added in. But I read this with such alarm. I think there's quite the scandal here hiding between these layers of bureaucracy, some really complex accountancy, and frankly quite turgid minutes, and I really love our NHS. I'm sure you all do too, and sometimes it's really uncomfortable to come here and to challenge robustly in the way that we're required to. Oh God, excuse my family. But at the same time, it's clear that these cultural issues talk to a lack of challenge of the UHL by the UHL board. And so what I'd like, and I've got a suggestion for you. I guess I'll be seeking assurance now and into the future that the UHL board has considered and continues to consider. I've shamelessly pilfered these 5 questions from a late great. But they are: what power have you got? Where did you get it from? In whose interests do you use it? To whom are you accountable, and how do we get rid of you? And I think they're massive questions. They're Tony Tony Benn's 5 essential questions of democracy. But I come to these meetings and sometimes have continued to feel that my questioning as an elected representative of the public is unwelcomed. So how can we embed further into the culture at this time? Hopefully positive, constructive, polite challenge, but that that you're building that in as you rebuild your board and recover. Thank you.
You can't beat the classics, Councillor March.
Oh no, shameless pilfering. Yeah.
Well, you know, it's always good. I'm sure the late Mr. Benn would not object to his words being continued after his passing. Councillor Sangster.
I think mine is similar, but not nearly as eloquent. I'm just impressed with that, Councillor March. Anyway, I heard you say that, did you say a third of the board members had resigned?
Over a third have left, yes.
And they have been replaced?
Yeah.
My question is, are you choosing from the same pool? So how do people, it's yours, I've told you, Councillor March, it's yours. How do people get chosen? What are the systems that you're using to ensure that you're not recruiting again in your own image? Given the diversity that is in fact Leicester, how does your board reflect that diversity and the pool from which you are choosing the new board members? I'm impressed that people would want to be on the board before it's fixed. So I think that's, I mean, you know, nothing succeeds like success. So I'm surprised and pleased for you that people are still wanting to be on your board. But my question is the board reflective of the communities it is serving? How were the people who have been replaced chosen? And what kind of, not simply skills mix, because, you know, accountant's an accountant, what kind of mix of class and gender and of course ethnicity does the new board reflect? Thank you.
Please, Rebecca. Rebecca, very interesting questions there. Rebecca.
Are you happy for me to come in? So if I just go to Councillor March's first, and just to say, you know, one of the things I would like to say is that this isn't a hidden scandal. I think this is something that we are absolutely want to be very transparent about. This situation should never have happened. It's a situation that will take probably for another 6 to 8 and maybe even a year to really not just put in place the corrective actions, but to actually put that real confidence issue, which I think is very important. The other thing is around that people feeling that UHL are defensive when they're having a conversation. I think that's something we've really got to reflect on. I think that's a really important point for us to reflect on, because, you know, this is our health service. You know, as a Leicestershire person, you know, this is my health service, and it is all of the people that we serve's health service, and we all should feel that we can question, and we shouldn't feel that there is a defensiveness. So that's something we need to reflect on and absolutely get right, because it, you know, we've got to learn, we've got to move forward. And there are so many very good things that we do, and I think we have been very, very proud of. And there are things that, you know, we, you know, as a community, we should be very proud of, to do with UHL and our health services across. One of them being vaccination, but there are lots of other things that we do and have done over the last many years for our public. This is one we've not got right, and we've got to get it right, and we've got to move forward. The board makeup is something that to be appointed onto a board, it's not just the trust decision, it's a decision that is made alongside our regional or even our national regulator, the NHSIE, and I will foresee that they'll have a much bigger involvement because of us being in financial special measures than you would see elsewhere. So in any NED appointment or chair appointment, you would absolutely, that has to be done and is driven by our NHSE colleagues. But I think you will see going forward, any appointment to our board, NHSEI will be much more involved. We do have a diverse group on our board currently, and of course losing our chair will change that dynamic. But we are hopeful that looking at our chair going forward, that will be somebody that is from our Leicestershire or Rutland population. It will be somebody that will be able to support us and be reflective of our service. We do have more women now than ever on the board. If you saw the board 3 years ago, there was one woman, and so that has changed quite dramatically. But one thing that we have looked at, and it has been a key priority, is around making sure people have the right credentials for the roles, and having strong accountants has been really important. The same way that we want to have strong clinicians to help us from the quality side of things. So I think we've got some way to go, like many boards have, but actually if you compared us to many boards, we were looking quite favourable with the characteristics, but we do need to keep that focus and make sure that we continue to represent our community.
Sorry, could I come back? Sorry.
Yeah,
Patrick.
please come back in, Councillor Sangster, and then I'll bring in Mark Whiteman.
I do like.
Sorry, I'll bring in Councillor Sangster, Councillor Fonseca, and then Mark Whiteman.
I do like it that you say you're hopeful that the board will be reflective, but if you're searching in the pools, if you always do what you always did, you'll always get what I mean. It's not news. I mean, I don't even want to finish a sentence. It's not news.
Yeah.
And so what are you doing specifically to ensure? Where are you looking now differently? How are you reaching out in a way that attracts a variety of people rather than, oh God, it's all cliches, isn't it? Stale male and old.
Yeah, I think to put it in a bit more of a management speak.
Oh yeah, better. Thank you. Go on.
You've got what I think is referred to in the trade as a closed loop system, where people from similar backgrounds, similar outlooks, similar positions, they're all there, and that's why there's no challenge, because it's almost the homogeneity. Councillor March said about the resistance to challenge, and I'll be frank, I've found that I've been chairing this committee nearly 2 years, and I do find that the various responses to challenge, which vary from the charming, where it's, well, surely we never do anything wrong, to the outright trying to block getting information. It is there, but in some senses, does the homogeneity of the board lead to this kind of closed loop system? And don't get me wrong, if you had a board full of mavericks, it would be an equal problem. But where is that? I think it's a really interesting line of questioning with that.
Thank you, Councillor Kittrick. That is a better restatement of my question. Thank you.
I know. Well, the thing is that's the thing about stealing somebody's good ideas. If you put them with some more fancy vocabulary, you can pass them off as your own. Councillor Fonseca, do you wish to ask about the board point, or is it a separate question? Councillor Fonseca? If you come back, Rebecca and Mark, to those points, and then we'll bring in Councillor Fonseca.
Sorry, Chair, it's just it's not a very big question. Yeah, this has to do with the statutory recommendations. There are 9 recommendations here, So how confident are you that it will be taken care of, and when will be the timeline, sort of? That's the question I want to ask. Yeah.
Okay, thank you very much, Councillor Fonseca. So if you come back to Councillor Sangster's point about how do we break open this closed club, because especially to be frank, national NHS getting involved doesn't particularly give me any greater confidence that will be the way to break a kind of a closed club. And Councillor Fonseca's point about the timescale for implementing the recommendations.
Okay, I'm just going to bring Mark in first, and then I'll bring up the rear, if that's okay.
Mark?
Yeah, thank you. And they're really good questions. And having read both Tony Benn's diaries and also Snowy White Peaks, then I know where you're coming from on this. The how you break open the club. I mean, I would give some of my colleagues currently and previously on the board their dues, that actually it's not quite the club it used to be when I first joined UHL. Rebecca's already referred to the makeup in terms of gender and also the makeup in terms of ethnicity, and all our non-exec directors as an example are not from well, they wouldn't give you a Mason's handshake, put it that way. But that almost belittles the point around, is there more to do on this? And I think, yes, there is. I'm not entirely sure what the answer to that is, and I'm not entirely sure how much of that is within our gift. The point that I wanted to come in on, which was directly related to Councillor Sangster's questions about how do you go about recruiting to some of these really very important positions, was just to, I don't know whether people know this, but whenever and I don't even know whether this is unique to Leicester or whether this is NHS per se, but when we previously have gone out to recruit for a new chairman or a new chairperson or a new chief executive, then the interview process involves stakeholder panels with a really wide range of stakeholders, including Health Watch colleagues. It involves patient groups, because clearly they're, speaking to Rebecca's point, the people who in general have usually paid for their health service for 40 years before they really need it. And they also include staff groups, a wide range of staff groups from across the organisation. And all that is part of the ultimate decision-making process about who gets some of these very big jobs like chief exec and chair. So it's not just a boys or girls club, but clearly we don't always get it right, and some of the stuff you're seeing at the moment speaks to that. But I'm not sure I can, on hand on heart, speak to how does the NHS per se or Leicester specifically now alter some of the nature of how we recruit, other than we have, through a lot of Karanjit's work, been determined to say, actually, we're getting it wrong unless our board and our senior management structure, and I include in that our senior clinical management structure, actually reflects the makeup of the population we serve. And you've heard us talk about this previously in this forum. You know, you take our 16,500 staff, they absolutely reflect the demographics of the population we serve. If you take our medical staff, they absolutely reflect the demographics of the population we serve. But once you get into senior positions, does that demographic reflection still hold true? And no, it doesn't.
Mm.
So I'm sorry, I'm not giving you an answer, but I've probably half answered at least the process question.
I think again, to use the hoary old management one, how can we tell what success will look like when we make these changes? If you just, you know, we know that people are trying to change, but how will we tell? And how will you tell? And probably particularly for Rebecca to say as the chief exec, when will you feel that we're making progress in those kind of cultural changes?
I mean, we know what good looks like, and good looks like where you have, you know, a board that reflects its community, be it whatever that community is, and that is really where we've got to get to. And I suppose I'm sitting here thinking, do I have an answer to this? And actually I don't. But what I do have is now have the push that you've given me to ensure that I now push where I can, because these are not a chief exec appointments, they're a chair appointment. But it's important that we ensure that our new chair recognizes what Leicester wants for its board. And that's what I've got to do, and I've got to push towards when we're looking at recruiting to these posts. And so I can't say it's going to happen overnight, but I can absolutely say when, you know, we will be going out to recruit an interim chair and a substantive chair, we need to make sure that that person understands the want of Leicester to have boards which are appropriately, I was going to say manned, have the right participants on, because, you know, I fought that all my life, you know, and I need to make sure that we do this right. But I don't have the answer now, Chair, but I will take that on board. And it may be when our new chair is appointed that we could ask them to come to the Scrutiny Committee to have this conversation again, because I think that would be really helpful.
It would be quite nice if the committee was involved in the process.
Exactly, bloody hell, we can watch.
Yeah, and if you can take that away as a recommendation, maybe if they meet us, they may not want to be the chair, but who knows?
I'll say nothing.
Well, it will certainly be a test. Councillor March, did you wish to come back in, and also Councillor Sangster, is there any specific targets? I'm probably broadening that out with Councillor Fonseca's thing about the timeline in terms of the recommendation. So if I bring Councillor March in, and then if we go on to the subject of targets for change, Councillor March.
Thank you, Chair, and thank you for that. And I don't want to diminish the challenges that are facing our NHS locally, as you put it, Rebecca, you know, and I really recognise the scale of all of those challenges individually, let alone collectively. So it continues to be sometimes uncomfortable for us to question the NHS because we love it, and yet also it's about public duty. And I just, you know, it's just to implore you to see Scrutiny as a critical friend, really, especially here. You know, we are the party of the NHS, the Labour Party is, and everybody here loves it for different reasons and in different ways, and has 101 personal reasons to continue to do so. So, you know, please see us in that way, and certainly those changes that you outline, and that cultural shift that needs to happen, is something that that I certainly continue to support. Thank you.
If I might move on to some of the more prosaic questions, which probably are a bit more technical, is there was when you read the report, there's kind of an infamous audit committee meeting when challenged, the response was the auditors are being a bit critical.
Yes.
Shall we get rid of the auditors? Is there anybody left from that audit committee meeting, and if there is, how did they conduct themselves? Because I've sat on audit committees, and I'm fully aware that there is the requirement to rotate auditors for very good reasons, but it seemed that they found a special impetus to do that. Is anybody left from that audit committee meeting and that audit committee process?
Do you mean in the trust as it stands now? So yeah. we would, I think there probably is 2 of the NEDs that are that still are on serving on the board, that were part of that audit committee. And that audit committee, you know, again, just to be really frank about that audit committee, the audit committee chair was very adamant that she was not getting the information that she required from our finance department.
Yeah.
And so I think there is, there absolutely is a real shared responsibility that this, whilst there absolutely that scrutiny and that assurance piece from our NEDs, but actually they were let down dreadfully from the finance provision very much at that committee. And that is the bit that we've absolutely had to put right going forward.
Yeah, and if you're looking for suggestions, believe you me, as a chair of a scrutiny committee, information doesn't fall into my lap either, and I have to scrap a bit to get things out of various people. So I would advise actually sometimes assertiveness, and we asked but the information wasn't supplied. It doesn't really cut the mustard in terms of, certainly if you're in the chair's role, and I think we do need to empower chairs of committees to do that. I'll leave the members who were members of that audit committee, because I'm sure I'll come to that with the Deloitte's work later. Some more of the technical questions. PricewaterhouseCoopers were the internal auditors during this period. I'm just checking my understanding. So what they're a bit of a spectre at the feast. So why didn't they pick up any of this was going on? Or please talk us through that.
This is a really interesting question, and one that we have looked at in some detail. So one of the key, and I'm going to probably bring Jonathan in as well, if that's okay, Chair, but one of the key issues here is the internal audit program, we put that together as an executive team and then as a board, so we can put that scrutiny where we feel it's the most appropriate to be. And whilst we had a good many days looking at finance, they were mainly focused on certain policies rather than probably looking at the detail that we should have been advising them to look at. So that, of course, puts them in a position where they are being kept in the dark in a situation. Now, I'm going to bring Jonathan in because he will say this again, much technically far better than me, but I just wanted to call a spade in that as well, Chair. So, Jonathan, if you could just come in on this point.
Yeah, thank you, Rebecca. So, very much as Rebecca says, it is incumbent upon the trust to direct the internal audit plan appropriately, and looking at the internal audit plan for 1920, a good example was it was looking at for instance, around our recovery of patient debt, which isn't necessarily an issue that we've identified in the review of the accounts. So how that audit plan was directed didn't lead itself to identifying the issues that we've recently discovered. What we're now doing moving forward is very much focusing the audit plan now on the key parts of our improvement journey. So a really good example that we've just recently been doing a lot of work on and continue to do so is our journal authorization and control process. So clearly we are then directing internal audit to review those improvements that we've made and to give us assurance that those improvements are embedded, because that's particularly important in terms of the control environment to the general ledger to be a really critical issue in terms of literally getting that assurance that all of the things we're doing are bringing the benefits that we need, but also actually using internal audit as a critical friend around further improvements that we can make. So I think, as Rebecca said, it is very much how we direct that internal audit plan.
So just the apologies, because I'm sure we could talk about audit all night, and to the fascination of our fellow committee members. But just to check my understanding, and let me put it crudely because it tends to cut to the chase, PwC were more or less sent on wild goose chases with busy work when actually the big questions weren't being addressed by the audit. I know that's a very crude broad brush, but I'm trying to get to, you've got an internal audit there, you had this big problem, what were they doing? And from what I'm taking from you and I'm checking is essentially they were sent to look at things that really weren't the main event. Would that be possibly an unfair summation, but a roughly accurate one?
I think that the right focus of that team was they were not focused on the right things, and that is what we absolutely now have in place.
And who was, I mean, without naming individuals, who was directing that team then? Was it the audit committee, or was it senior members of the finance team?
It would have been a mixture of those, Chair.
Okay, and is that lesson somewhat learnt, that if the people who are being audited are in charge of directing the audit, that's not really a healthy situation, is it?
We've got a very much stronger, robust process now for our internal audit, and of course it's linked very much to the recommendations that we have to put in place, so that actually, you know, they're working very much to be that critical friend that Jonathan talked about.
Okay, let me dash through some of the more drier bits and observations. One is having read the audit committee papers, and I've expressed this to you before in other forums, is that the way that the minutes of committees read is they just say we went into private session, and you've no idea why it's gone into private session. And again, it's marking your own homework, as it were. You say you've gone into private session. We don't know whether that's because individuals be identified. We don't know whether it's commercially sensitive. We don't know whether it's been redacted because it doesn't look very good, and we're trying to hide problems. Again, is there any benchmarking on the amount of redactions? Do we kind of keep an eye on it, just as a temperature check about how much we're redacting? Because again, it may be normal, but I don't know, because I haven't seen what's redacted.
We very much, there's the rules that we follow are quite robust on this, and we are sort of kept very close to that, you know, that transparency of what goes in private and what goes in public by our governance director. And so I'm sort of comfortable with that approach. But the key thing is, what we need to be really clear is why we're going, because it's okay to say we are going to go into private because this is a commercially sensitive situation. If we're more explicit going forward of why we're going into private, then I think people reading those notes would be be clear on the reasons why, and then there wouldn't be that question. Because you know, what we can't do is go into private because we don't like the sound of what we're hearing. That isn't an appropriate reason to go into a private meeting. So I think going forward, picking up on what you said before, Chair, it's something that we will be making sure that we are learning from, and making sure that we're clear on the reasons why we're going into private, so there isn't that question of what are you trying to hide then.
Yeah, and again, the irony is it's auditing the audit. You would expect part of your audit would be to look when private session was taken and whether that was appropriate. Just again, getting into the really tedious numbers, Jonathan, do you think, is it nationally mandated? Do you think? And I appreciate you're a billion pound a year turnover. Do you think the materiality level of 16 million pounds, anything up to 16 million pounds out, is not material? Would you suggest lowering that materiality level, or in the very least make it operate so it isn't being abused, as it were, to hide mounting problems?
So there's in an audit process, there's an agreement on the percentage, and what that 16 million represented is very much, I think, 1.5% of trust turnover. Clearly, in light of the restating of all of the accounts and all the work we've been doing, we've been working to a lower materiality limit with Grant Thornton. So you very much agree, start at the percentage or the 1.5%, and then move that depending on where we are with our processes and what we've sort of unpicked. So I agree very much that 1.5% or 16 million isn't an appropriate value, and we've not been working to that with Grant Thornton in light of everything we've discovered. But it is very much a discussion around with your external auditor linked to where the assurance is on your processes. So at the time, that would have represented a level of assurance that clearly hasn't been the case, which is why we've got a different materiality limit now, and what we're working to through the current audit process.
Okay. And again, you may not be able to comment because you haven't had a full understanding. Is there any sense whether the £46 million gap occurred in 1 year, or was it a case of that they'd rolled it over, and a bit like somebody who's trying to hide it, the gap gets bigger and bigger over a number of years? Or was it do you think that £46 million was a one-off event?
Certainly through the work we were doing, there's a requirement for us to look back 2 financial years in terms of those prior year adjustments. So I can say it wasn't just it wasn't relating to 1 year, but it was relating to the year before as well. Yeah. Because we had a requirement to look at 2 years in terms of those adjustments that we've made.
Yeah. No, I'd be surprised if £46 million did appear in 1 year. So again, it speaks to that. And just in terms of just quickly before I go on to the other things, in terms of culture, ultimately, what's the sense of how many members of staff at UHL? And let me pick my words carefully. The word I'm not going to use is party, but how many employees at UHL were within the sphere of this maladministration and not responsible for it? But how? I think there was once some report about how many people actually had some involvement in Watergate. I'm kind of looking for a feel for how big was it in order to keep this situation going on in terms of individuals, because there's a discussion about finance staff being put under pressure to continue operating it. Broadly speaking, how many people are we talking about who were cajoled or managed into, to be frank, hiding this situation? Have you got a feeling for that? Because I'm trying to get my head around what was the extent of the cultural problems. If it was 5 individuals who were operating this, then it tends to tend towards, well, there was some real system weakness. If it was 50 individuals, and I'm not saying they're responsible, but if 50 individuals were, say, for example, being managed to hide this issue, then it speaks more to a much more fundamental cultural issue. Can you give us any indication on that front?
What I could say, I mean, I don't have the exact numbers, but what I would say is that because this was something that had been developed over years, which is what Jonathan has just explained, the custom and practice of our finance department was the issue here. I think whilst other people were challenged and trying to understand their situation, I don't think, whilst the people who are responsible for this are the board. We are the board and we take responsibility. But the custom and practice that was allowed to deliver or be created was predominantly within the finance department. That said, anybody outside of that, even though they questioned it and didn't do something about it, are they part of that culture? And I'd say yes, because actually people lost their voice when it came to money, and that's the cultural change that we want to get right now. So whilst those involved were very small numbers, those that didn't have a voice when should have had a voice, those numbers of course are much greater, and that's the big cultural change that we have to get in place. We know from a finance department the changes that we put in, the changes of policy, the rigor, the grip and control that people can and can't do things without certain approvals have sort of righted the bits that will stop this happening from the transactional side of it. But actually the cultural side is that, we should be, if we are concerned, we should be raising it and feel that we have a voice. And that's the cultural bit that we need to get right now.
Okay. Thanks for that. Councillor March, do you want to come back in?
I think Mark was asking to come in before me, but I'm happy either way.
Please, Mark, do you want to come back in first?
I think, Chair, I'll be taking us 10 minutes back on the discussion, so you probably won't thank me for it, but thank you anyway. All
right, Councillor March.
I guess my question then is about there's clearly a really tricky balance, isn't there? Because the financial challenges faced by the NHS that is grossly underfunded are not going away, and it's important that a board is robust when asking those questions and that doesn't shy away from asking them. But at the same time, there are so many other challenges, and you don't want to get into the position where there is pressure and influence coming that means that people are scared to present the scale of that challenge as it is. So I think there's a real challenge there. One of my questions, there's a lot of talk about training and development and kind of support for the board. And I guess there's a real problem, isn't there? If people are competent enough to realize that they need that, but if they're at a point where they don't realize that they need that, or they've lost their voice, or that the way in which the information is presented, they couldn't anticipate, or it being presented in another way that they might be able to digest it and get their head around it. There's three bits to that, aren't there? There's one about I don't get this and I don't care. There's one where I don't get that I don't get this. And there's one where I don't get this because of the way in which it's presented, and therefore I need to ask for different ways of it being presented to me. And because not everybody can be a qualified accountant, but everybody would have something useful to be able to contribute to that debate probably. And so there's three different bits there that I don't know if they're helpful or not, but to because the scale of that challenge isn't going to diminish. And I mean, we all of course hope that it doesn't get worse, but it's really important to make sure that people not only continue to have a voice in that area, but actually are supported to find it. And if there are issues, that they are being helped to bridge the gap between being a professional accountant and being able to understand what they're being asked to ask questions about.
Thank you, Melissa. If I bring Jonathan Shooter's asked to come in, I'll then go back to Rebecca, and then I'll tell you what. If I bring Jonathan in, I'll then add my comments to Melissa's, just to try and bring this to a close as the evening's going on, and I suspect that we will come back to this again when more development work's been done. Jonathan.
Yeah, thank you. I just wanted to pick up. It was actually Melissa just sort of drew this out around particularly. I just wanted to draw out obviously really being critical in terms of the professional responsibility of the senior finance team or senior accountants. Two things really. One is to in terms of those complex accounting treatment or issues, to do those things properly in line with accounting standards and professional requirements, but also probably really more importantly, well, equally important, actually, is to explain those issues in a way that non-accountants understand very easily. And it's clear that wasn't being done in terms of particularly the improvements we're making now on financial reporting, to explain those complex issues in a way that the board can challenge and do that board role of confirm and challenge and questioning in a way that the information is very understandable. And that's a critical part of the financial improvement journey we're on at the moment, to explain complex issues in a way that makes it really easy for non-accountants to understand and question.
No, it is indeed. To understand accountancy is possible. To try and explain it is a completely different scale of challenge. So I mean, again, and I'll give you the last word, Rebecca. I think we've heard a lot about particularly the recruitment of the chair process, and I think if we're asking, if we're being blunt, we here at City Health Scrutiny would like a role in that. Even if we can't choose, we would like to be as involved as is practically possible, to give our input. Whether it's listened to is up to those who are choosing. I think we've heard that we need to kind of break out of a bit of a club. That process has been done. Still more needs to be done. when I think there's a specific piece of work to be kept in the loop on the break-even strategy for UHL. You've described that this year will be break-even, but it's a case of clearly it's COVID times and COVID funding, so it's not a usual year. And any break-even strategy will have impacts, I'm sure, on services, be they through efficiencies, which may have impacts, or it may be actual cuts. So we would like to keep abreast of what's happening with the break-even, particularly as I've seen in the audit reports, some recognition that the funding levels simply do not allow a break-even if the current makeup is there. We want to see what checks and balances will be in place. We've had some of them tonight, and you've already outlined them, so I think we're on the way there. We're aware that you're doing the board development programme with Deloitte. Can we get an assurance that we as a committee will see that in some form? So as it were, this continuing debate about governance and how that's developed, that if we don't scrutinise the full report, and certainly that would be information overload, that we have access to at least any executive recommendations, and you can come back and talk us through that work when that work with Deloitte is more fully formed and you more fully understand it. So if you come back to those points that are put forward, and they're kind of just to annoy Jason, they're in the, who's taking down the notes, they are in the way of recommendations about involvement in the selection of chair, the new chair of the UHL board, the discussions about being involved in that debate about how UHL gets towards break even, the checks and balances, and the report back on what Deloitte's conclusions are as they seek to develop the board. And the final question is within all of this financial maelstrom, does that have any implications for the hospital's plan that we hope will be successful? Rebecca.
Yeah, thank you, Chair. So if I just go backwards, so we have not had anybody say to us in any way that our 450 million is at risk. And, you know, we have very regular conversations with the ministers involved and the team involved. And of course, people will put 2 and 2 together and try and make 7. And as an organisation, one of the key things, and Andy is also supporting us with this, is making sure that we are being very, very clear and very transparent with this process, and ensuring that those nationally and people locally know that, you know, there is no talk of the 450 million pounds being at risk. And, you know, the changes that we've made, the improvements that we have made will all be scrutinised, and of course they will all help support that's our position with the 450 million. But everything is still systems go. We've done, remember, you know, we've been through a pandemic, we've kept the improvements going on our financial position, and we've been out of consultation with the reconfiguration. This is such an important point. And I remember when we first sat together as an exec team with our senior leaders in the organisation, and we were about to go through this pandemic, and I said, and I remember saying to everybody, we have got to do everything we can to keep our patients safe. We're about to go through the biggest pandemic, you know, since World War II, the biggest event in our country. But like no other hospital, we've got 2 other things that we've got to do. So we've got to keep our patients safe like every other hospital, but we have got to focus on our recovery financial plan, and we've absolutely got to keep our fingers on the pulse with reconfiguration and the consultation. And I'm proud to say our system has worked together with us on this, and we've been able to put ourselves in the best position we can. You know, we've not faltered on any information, anything that's been required. And of course, with such a massive big reconfiguration, you have constantly people requiring lots of different information, and you know, we've been able to be at the forefront of all of that. The information from Deloitte, a lot of that, we are again going to be very happy to be transparent with that information. A lot of it will be around board development, team development, individual development. how the committees work, the structures work. And again, you know, very happy as appropriate, unless it is commercially sensitive for Deloitte, very happy to share that as we move forwards. The discussion on a break even, of course, this is something that we should all be involved in, because, you know, to get the NHS and social care together into a break even position is very, very important. Not, you know, I'd say there's only one or two at most, a very small handful of systems that are at break even. We have got a plan to do, we've got to do it, and the only way we can do that is by being radical with our transformation, putting care closer to home, investing in place, shrinking the hospital where appropriate. You know, we have to be honest. And that's something we can't do in isolation. So I know together with the system, we would look to you as important partners in the scrutiny of that, to making sure it's robust. And the involvement in the chair, I will certainly feed that up to our regional team to make sure that we've got good partner engagement in our, it may not be for the interim one, because that may just be a quick appointment with Cramjit leaving, but the substantive post, where I can, I will make sure, you know, I share that influence and the stuff that you've talked about today with that discussion. Okay.
Thank you very much, Rebecca. Thank you for coming to this committee. I sincerely wish, and I'm sure you sincerely wish, that it was in better circumstances. But certainly in terms of the information and the engagement you presented tonight, I think we're on track. But but there's a lot more work that needs to be done. I think the process of change is underway. But as you've frankly admitted, change doesn't happen quickly, unfortunately, especially with some of the cultural issues. Yeah, so we've made a note of the recommendations. If the committee's happy with those recommendations that I've outlined earlier, thank you very much for your attendance.
Thank you. Thanks, everybody.
Yes, thanks very much. We're about to go on to Leicester Partnership Trust items, which are item 11 and 12. What I'm going to suggest is that we have a break until 8:10. My apologies to our friends from the Partnership Trust. As I'm sure you can understand, I do appreciate that we've been going for 2.5 hours, but the subjects that we've been going to, you know, the COVID response and COVID vaccination, and £46 million financial misstatement are substantial items that I do think merited the time. So if we take a break now and then adjourn, and if we return at 8:10 to deal with the rest of the agenda, hopefully we will be finished in good time, certainly before 9 o'clock this evening. So I'll adjourn the meeting until 8:10. Thank you. Welcome back to the Health Scrutiny Committee. We now move on then to item number 11 and 12, which are both presented by Leicester Partnership Trust. So if I can hand over to officers of the Partnership Trust to introduce the next two items, please.
Thank you, Chair. I'm just going to do a little brief introduction, if I may. Angela Hillary, Chief Executive, before I bring others on. So good evening, councillors. Thank you for the opportunity for us to share two items of update with you this evening. Firstly, really importantly, update on our adult and older adult mental health, which will give us an opportunity to reflect a little bit in terms of what's been happening over 2020, but also to look forward into 2021. I'd like to also, before we start, say how importantly partners have been in getting us to this point in terms of what we're sharing today. And then I've got Dr. Anne Scott with us for the second item, who will give us an opportunity to look at the improvement journey overall in quality in LPT through the last period, so that everybody's clear about our journey and improvement together. So without further ado, I'm going to ask Gordon King, our Director of Mental Health, and John Edwards, our Associate Director of Transformation, to take the committee through the adult and older adult mental health piece. Thank you, Chair.
Thank you, Angela. Thank you, Chair. Thank you, councillors. Yes, we'll try and make this a pretty brief update. The Commissioners, this committee and Commission is fairly well versed, hopefully, on the adult and older people mental health transformation Step Up to Great Mental Health programme, and was, as Angela pointed out, has been a very strong partner in supporting us and getting us to this place. It's getting to a very interesting and fairly crunchy place, actually, in terms of where we're going with this now. And subsequent to the previous Commission's scrutiny on this, NHS England's Clinical Senate have also been supportive in their scrutiny and agreement that this plan is to progress. Obviously, we've got some more work to do in terms of engagement, which John will touch upon now. But just very briefly, I think, John, this Commission wanted a brief update at this particular meeting. So I think John's just going to take us a few very quick slides, and then obviously we'll be more than happy to take some questions. John Edwards is here now, and he'll do that.
Gordon. Okay, I'm trying my best to turn the slides. Oh, we go. Right. So I know the panel would have received these slides beforehand, so I won't take you through it in full depth, but just to flag, as you'll be well aware, that mental health services have had historical challenges, particularly in the form of long waits for treatment. We had a history of people being sent out of the system to inpatient accommodation, and a range of poor experience and issues in meeting the diversity of our population. Across COVID, across 2020, obviously with the COVID conditions, we've had various impacts from that. It has disrupted our waits further, and whilst we have been actively focusing on trying to tackle it, it's been an ongoing challenge. We've implemented things like virtual technology, which has been particularly difficult for the clientele that use mental health services, and we've had to adapt across the year to try and still meet people's needs through these COVID conditions. We've seen increased demand for phone calls in particular, and I'll talk a little bit about what we've put in place, which has allowed people to ring us. But in terms of actual referrals into secondary mental health services, that's actually diminished during the COVID. Although it's too early to be clear whether that's a sustaining picture or whether that's some of the conditions that get affected by the changes that come in with COVID. So the challenges expected over the next 3 years is still being modelled nationally, and we've done work with partners in the Midlands, really working on trying to get a sophisticated model together. And we've with their support, we've actually got an ongoing model that we're working with that's starting to forecast an expectation of increased growth within mental health. And what we can see, which you've probably picked up on in national media and the like, is a real impact on ethnic minorities and lower socioeconomics and the widening gap of need that we're going to have a particular focus and attention on over the coming years. The progress that we've made, which we've had an opportunity previously to talk a bit about to yourselves, is that we've implemented a way that people can directly access us through central access point through ringing a number, and that's been strengthened with support from third sector partners from December, and we're really proud of what we've managed to offer there to people to really offer some help and support. We've got improvements to people that are in a case of emergency with alternatives to the emergency department delivered through Urgent Care Hub, and changes to our community services and really thinking about how we support people out of hospital environments in a community setting. We're particularly proud that we've sustained not sending anybody out of area inappropriately for an inpatient placement over the course of the vast majority of 2020 and leading into this year. And we would really stand out nationally, actually, as being able to hold that position. It's something that we work very hard to continue. As indicated, that we continue to work very closely and really seeing strengthening of partnership across this period, and that's something that we're really building on going forward. and we've had a lot of success in bidding for new monies as well to bring into the system, with a multi-million investment coming into this local system to really enhance and support the transformation of mental health services that I'll touch on now. So as we're heading into the future, we have got a very clear national ambition around really stepping up mental health services and bringing a level of parity of esteem across other health systems, every part of the health system. And that's being supported by investment I've referred to. It's all designed around trying to deliver services very much more locally and more targeted to local populations, as well as strengthening the mental health expertise and bringing together a much stronger partnership with voluntary sector, local GPs through primary care networks and social care partners. There is a model that we've been building with some pathfinders, and I'll explain one of the pathfinders that we've been running in the city, and it's starting to shape up about a model of how and what we should be delivering locally to best meet people's needs. I just wanted to touch on then, just to frame for you the kind of things to be that we really want your support in the ongoing engagement around. So to get ready for that future vision of having really well connected, joined up services in local areas, we first need to be working with reconfiguring the services that we've been having for many years. And that's going to be subject to public consultation, which we explained to the Joint Health Overview Scrutiny Committee a couple of months back. The expectation at the moment is that we would start a public consultation probably in May, after PERDA has been finished within the county. And so that will run for 3 months. We're really trying to make sure that we engage as many people and as widely as possible, and hope that that engagement really persists beyond the consultation period to help us co-produce the delivery of the new model of care, and as we move forward, really bringing together services that really work for local populations. So just to leave you with really thinking about, we are running a pathfinder of that sort of new model, and that's just at the foothills of getting going in Belgrave and Spinney area, and so would be very interested in any connections that you have in that local area that you wouldn't wish to flag to us about trying to connect people into that work, because it's really important that we shape it well. We really would like your support in maximising connection with the public consultation and the advertisement of that, because we want to really reach as many people as possible, and support then their involvement going forward. And our continued focus on really trying to address the inequalities that we know we've got, both in the population and the system, and helping our continual work in trying to reduce those. And the ongoing promotion of mental health, it's been a particularly challenging year and continues to be for a lot of people. And it's not going to be a solution solely within mental health services. It's about how communities come together and support people during these times as well. And there's been some important work done in the city through the Time to Change, and we're trying to work with public health colleagues to really think about how we can promote mental health friendly communities and the mental health first aid rollouts as well. And thinking very carefully about the 5 ways to wellbeing, which has got a strong evidence base of supporting people to be more resilient. So I'll stop there and for questions.
Thank you very much. If councillors wish to indicate whether they want to come in the chat bar or they just want to chip in. If I start, I'll ask the obvious question whilst people are putting their questions together. You've targeted Belgrave and Spinney, and clearly, how does COVID and affect your engagement strategy? And then I'll bring in Councillor March.
So when it comes to engagement strategy in Belgrave and Spinney specifically, or just in general through the public?
Well, yeah, in general, but it is quite interesting that you highlighted Spinney, which again was the epicenter of a lot of the discussions we were having tonight.
Yeah, well, the reason the selection of Belgrave and Spinney is to do with as much about the population as it is to do with.
No, it's not why were they chosen. Sorry, my apologies. Sorry to cut in.
Give me Patrick.
It's how will COVID affect your engagement in that community sense?
I think it changes it, and this will be true in the terms of the public consultation. We're working very closely with voluntary sector that have already better established relationships with local population than we do, and have improved mechanisms to engage with people. So there's something about how partners can help us, and through the public consultation in particular, we're also going to be investing a bit into voluntary sector to help us to try to reach people. We're having to work on the virtual media as you'd appreciate, because that's the safest mechanism to engage, and we're working up as we speak other mechanisms to try and reach people that aren't going to find it easy or are in some level of digital poverty. But I haven't got the full ins and outs of those plans here at this moment.
Okay, thank you very much, John. I've got questions from Councillor March, Councillor Sangster and Councillor Fonseca. So if I bring in Councillor March, first of all.
Thank you, Chair, and thank you, Angela, John and Gordon. Something's just changed on my screen. Okay, I'm still here. So my question, firstly, I really welcome this item because I have huge concerns, I guess, about mental health in the city post COVID and the impact that COVID has. Surely it's going to have increased that. I'm kind of aware of that. Obviously, there is loss, but I also think people who, for example, have key workers who've worried about bringing home what they're bringing home to themselves, to their families as a result of their work anxiety, and people who are shielding I guess all sorts of challenges that we'll see in people who've had to work, for example, on ventilation and other wards in the hospitals. I'm very worried about the impact of COVID on longer term in the city, especially given how Leicester has been treated and kind of the higher rates that we've seen and the extended lockdown and all of the stuff that's happened in the city. So my first question is about that. My second question is that I really welcome the approach as you've outlined it, but I wonder that this kind of the transformation of mental health services at the scale that we need to do them really requires financial backing and that whilst there are some one-off pieces, it looks like of capital funding, but we really need I guess clinicians on the ground with the skills who are able to do that. So that's my second question. Have we got those, or what plans do we have around that? I've got two more. My third question is that I really value and recognise the role of things like resilience and self-help, but if you're having a mental health crisis, they're really no substitute for the professional input that you might require. So how do we making sure that people are intersecting with mental health services at the right point, not just the kind of the lowest the cheapest, the most widely available kind of points? And finally, Gordon, I apologise because I know we've talked about this one before, but it is anyone who's sat in health with me, scrutiny with me, knows that I do bang on about bed numbers a lot. And I finally got an answer about my bed numbers at the acute Bradgate site. So with the removal of dormitory accommodation, which of course I fully support, but there is a loss of 24 beds, moving I think from 140 acute mental health beds to 116 at a time at which I, as a lay person, guess is going to be increased delivery. So how do we justify that, and do we think that's sufficient, or have we got plans to expand that, please? Thank you.
If you want to pick up Councillor March's point, I will then bring in Councillor Sangster and Councillor Fonseca.
I will do. I'll try and address them in order. Firstly, we're very closely working around the research, looking at the research on, and talking to our service users and carers about the impact, and our staff of the impact on COVID. And you're absolutely right. It is substantial, and it's likely to be substantial for the city. And That's something that I think we can, the way that we're developing this, as you pointed out, is through partnership. And I think that will be the only way we'll do this, actually, that we'll actually manage this across the piece over the next year or two, because I think it is a substantial challenge for all of us, including staff, as you rightly point out. Obviously, we've been doing quite a lot of work on Staff Wellbeing Hub, which we've now got some funding for this year. Which I think is really, really important. And that's obviously going to be very helpful in terms of supporting staff across the system. In terms of service users, the research is interesting. It's quite varied in terms of what we're expecting. John alluded to a slight reduction at some point last year in secondary mental health referrals. That seems to be changing slightly now as we move into this stage of the pandemic. There's something around resilience, and there's something around the different populations that we're working very closely on, looking at those populations that, particularly around the intersectionality, who seem to be most challenged by mental health, and who we know have got the most some significant determinants of ill health from a mental health perspective anyway. But it's quite a varied picture, actually, Councillor Marsh, and it's very interesting. So we're going to have to continue to do some work about where do we best put our focus, on what groups do we know are going to be most impacted. So we will continue to do that. The money is an important issue, of course, always is. I think I've said before, I've been in mental health now for very nearly 40 years, and I think we're at fairly unusual circumstances here in terms of some of the investments we're now getting through, both for our crisis and urgent pathway, and most recently for the CMHT transformation. So I think there is some genuine investment coming. Some of that's recurrent stuff for transformation, some of that may well be capital stuff for rebuilds, etc. But I think we are in a slightly better position than I've known in the past. The trick is to make sure we use that money sensibly and well, and for the benefit of our service users and for the wider population, particularly for those populations that need it most. So that's what we're going to be doing, and hopefully our transformation gets us in the right place. Your point around the real help needed as well as just well-being is absolutely right, and I guess hopefully I've covered that off in the first point I mentioned. And the last point, Councillor Marsh, around bed numbers is an incredibly important one. You're absolutely right. We were keen to get you that information. I'm sorry, there's a slight delay in it. It's partly because the plans are changing slightly on an iterative basis as we try and work through the twin-tracked challenges of, on the one hand, thinking about the absolute necessity from NHS England and from our service users' perspective about eliminating dormitories and the limitations of the estate we've got to be able to do that, and at the same time the shifting and changing challenges we've had around how to manage our COVID and our inpatient stock safely, which I think we've done broadly with our service users. We're very proud of what we've achieved through COVID in terms of keeping our service users safe in an inpatient setting. It's not an easy thing to do. So it's been a bit of a movable issue, actually. In terms of the numbers, those numbers are the most accurate we've got at the moment in terms of what we expect over the next 2 to 3 years in terms of reduction from the initial bed base. I think it's probably worth pointing out that this is all predicated, I think I've said this before, on making sure that the transformation delivers and continues to deliver on the sorts of community changes we need to keep those bed levels in a reasonable state. If I can let you know now that we're actually using something on any day at the moment, there are roughly 100 people less in our community in an inpatient bed than there were at the start of COVID. So not only have we reduced and removed the 50 or so, just under 50 at one point, out of areas. So in other words, Leicester residents, Leicestershire residents, and Rutland residents who were placed often many, many miles away, sometimes in private beds, sometimes in NHS beds. But we've also, by necessity, had to reduce our existing bed stock to manage COVID safely, to make sure we had enough staff to move around and to make sure that we managed the flow effectively. So we're actually around, just in terms of our existing bed stock, something like 44 beds down in acute and slightly more in, slightly less in our rehab, which we've been using to support community rehab. So I'm not suggesting that they're the numbers that will stay. I guess what I'm saying is we're already working to reduce bed base. We're still not putting people out. It's a year now since we've placed anybody out of area. We're hopeful that if we can continue to manage our community transformation in the way that we think it's going to happen, and to improve the crisis pathways, crisis cafes, and continue to do the work we're doing, that we think we'll be able to manage with the reduction of beds that I outlined to you from the original bed stock, But there are some caveats in that, and I think you'd expect me to say that we're keeping a very, very close scrutiny on it. And obviously my board are holding me to account on that to make sure that that the transformation does deliver those changes, and that we're not going to be in a position where we don't have enough beds for our population. But I think it's something that, you know, we'll welcome further conversations on, and we're working on very, very closely.
Angela, you want to come in?
Yes, thank you, Chair. I just think it's really welcome, Councillor March, to have the focus you've described in terms of how we're going to understand the impact on our people and our staff, as Gordon has mentioned. But I think we're going to have a collective role to understand what health inequalities look like, because increasingly we know COVID has shone a lens on the health inequalities, but in mental health we've had that lens there for some time, and I think we would want to work collectively with you to make sure the resources for mental health are allocated and that we do have an opportunity to improve outcomes together, because clearly resources will be needed for mental health, and that also is why we've done the work that we've done regionally, so that we can look at data that we have in mental health that is just not available nationally. We've developed that in the East Midlands, and we're really pleased we've done that, because there isn't the same level of data about mental health need collectively that it does exist in the acute sectors. So more to follow on that as well.
Councillor Sangster.
Hi. Before I start, the disproportionate numbers of African heritage people coming into mental health service late, does that still exist in Leicester? So they're more likely, so that African heritage people are more likely to present at crisis than to make use of available prevention or support services. Is that still current in Leicester?
Well, we're doing some work on that at the moment in terms of trying to identify what that looks like. It's actually not an easy thing to pin down, but you'll know, and I know, the historic picture nationally has been exactly that. And it's been extraordinarily worrying about how that's happened. We're beginning to do some detailed work on our data at the moment, and I think you and I know that we've got a conversation planned about how we can think about taking that further into the communities, about making sure that you address the three things that I think are needed. Firstly, services that are targeted and focused on the needs of people from Black communities and the wider BME community. Secondly, the community conversations needed to make sure that all the other factors that come into play in terms of making sure that people are able to access and supported to access services as quickly as possible. And thirdly, the work needed culturally to make sure that all of that is embedded in the services. And that's the kind of work that we're doing at the moment. It's interesting that the data nationally seems to be changing slightly, which is hopeful. It's changing in a hopeful way, but I think there's a lot more work to do on that. And I don't think Leicester's exempt from that at all.
Okay, so you don't have the data yet to tell me whether what existed previously, whether it's changed or it's the same. So that's okay. That's okay. I realise it's coming. I heard from John, Mr. Edwards, that there's a public consultation starting.
Yeah, correct.
Yeah. When is that starting, and how are you reaching out to African heritage communities?
It's an extremely good question. I'll let John pick up the detail on that.
The consultation is due to start on in May. There's engagement planned in March with local community groups to start to try to work out how the best way to engage the various different communities within Leicester. And I'll have to pick that up in terms of the specific community that you're referring to, in terms of exactly which groups have been engaged with that, just to confirm that we have got coverage.
Okay, I don't understand your answer. I'm really sorry.
So I think that we're doing some, if I can come in, I think we are doing some detailed work with the CCG colleagues and with our own comms team about ensuring that we reach the widest possible group in terms of the consultation as it runs out through May. I've got conversations with Councillor Dempster and other exec council colleagues around specifically looking at the needs of Black service users, and we're also working with our own service user group and carer groups, specifically around wider BAME groups. And we're also making sure that we've got other groups with protected characteristics and some specific intersectionality issues that we're beginning to look at and address. And there's going to be some more work on that over the next few weeks. So we do have a plan, but I think it's fair to say it's still emerging.
Okay, in that plan, is there scope for, because what we know about the African heritage, I keep banging on about African heritage, and what's really important here is that my politics, my understanding of life says that if you start at the bottom and work up, then what's good for the people at the bottom will impact on will impact on other people. So it kind of gives you a formula of work. And what we do know is that what we do, thank you for that. What we do know is that African heritage communities are underserved, underreached, and are more likely to present at crisis. So if we work with those communities, then the generalizable good will go out. So when I'm talking about African heritage communities, I'm speaking specifically but not exclusively. Okay, so what inroads have you made into the African heritage voluntary sector, number one, and what scope is there for capacity building? Because as you know, that voluntary sector is particularly fragile. If you go to Voluntary Action Leicester, which is where people usually start when they say they're going to do some work with the voluntary sector, I'm not sure you'll find more than one African heritage organisation there.
Well, I think that's the challenge, isn't it? To make sure that we're talking to the right people. And that's one of the things.
My question was not if you're talking to the right people, because I'm sure you want to. My question was, what scope is there for capacity building in that voluntary sector that is the most fragile? So if the sector that you're trying to reach out to has been decimated and underfunded, then how are you going to reach out when the sector is fragile in and of itself? You can't do that without some capacity building, is what I'm trying to ask.
I agree entirely. I mean, I think you're absolutely right. I mean, it's possibly a long conversation around the VCS in this system, but I think many people would agree that particularly within the mental health sphere, it needs some growth and it needs some support. We've been incredibly clear that that's exactly what we want to do at LPT. And we've been incredibly clear with CCG colleagues that that's going to be a significant part of the plan. And if we get inside the detail of Step Up to Great, it's absolutely threaded through with the need for us to support, grow and develop partnerships with the widest range of voluntary sector organisations, and absolutely to support investment in that. And we're going to be doing some specifically targeted bits on that, partly with PCNs and partly directly with VCS. Angela and I had a conversation about that last week about how we can address that. And it's one of the conversations I wanted to have with you directly when we meet on the 22nd of March, Councillor Sangster, as part of our dialogue on that. So I would agree with you. It's our commitment to do that, and specifically around working, and I've already met with some of the BAME VCS organisations, but specifically around African heritage, and I'm very, very keen to continue to grow and support that. I can't comment about the historic underfunding in this system, but I certainly see a need for it to be developed and grow. I don't think there's any doubt about that. And I think long gone are the days when secondary mental health services took a different view on that, in my view.
Okay, so here I am kicking at a very open door. I'm going to continue kicking. I'm going to continue kicking because I've got another question.
I'm grateful for you to keep the challenger, because it's one of the most important things that we can possibly face in the next year or two, particularly post-COVID. So I'm extremely grateful for the challenge, and I'm looking forward to working with you and other colleagues on it.
I understand that you said you've got a strategy, and I'd like to know how or whether you can extrapolate from that strategy, because it has to be woven through, obviously, but you can extrapolate from that strategy short, medium and long-term goals about impacting particularly African heritage community, because I've said, as I suggest, that will offer a generalizable approach. So can we extrapolate the goals from the strategy that are specifically intended to address the African heritage need?
Yes, I think we probably can.
There's that open door kicked again. There you go. Thank you very much.
and I think we'd want to. And I think specifically looking at the needs of specific groups has been a core part of our work over the last year. So again, open door, but welcome for the challenge, and looking forward to working with you on how we can do that. And hopefully the conversations you and I have got laid out in the next few weeks will help us shape that.
Okay, right. Well, thank you very much. That's the end of that then. Thanks.
Thanks,
I'll see you on the
Deborah.
22nd. Yeah, okay. Sorry, Patrick. Thank you.
Thank you, Deborah. Councillor Fonseca.
Yeah, thank you, Chair. My question is in regard to parity of esteem. A lot has been spoken about parity of esteem prior to COVID. I'm not sure where are we with that now. How has COVID impacted that? Parity of esteem, when I say it's health, mental health versus physical acute hospital health. Second point, I have three more questions, please. Second point is about the central access point. Can you elaborate on that a bit more? And as you rightly said, in fact, for mentally for mental health people, it's I mean, using internet is very difficult, and they have to have more access face to face, or rather through phone. So have you increased on that basis? I mean, as anything, as you sort of tried to address that, and then you spoke about a urgent care hub. So urgent care hub, where is it in fact? And then again, the Bradgate money, the money, of course, you touched upon that. In fact, about the refurbishment and about transformation. But will Bradgate had always been a sort of a bane to LPT in terms of CQC. Of course, we'll be touching on that later on. But do we have any spending on at least partly rebuilding that center? Thank you, Chair.
Thank you, Councillor Fonseca. If I may address those in turn, I might be that Angela wants to pick up the last point around the build and Bradgate. Oh, I'm happy to. The first one, parity of esteem. I think it's a mixed picture, Councillor Fonseca. I think on the one hand, obviously, COVID has focused hugely on physical healthcare by its necessity, and specifically around, ICU capacity and the way that urgent care within general district hospitals has been managed within A&E, all of that. But at the same time, I think it's also, brought to the forefront of people's minds the interlinking, the completely inescapable link between physical and mental health and well-being. And Councillor Marsh kind of alluded to that earlier, I think quite rightly. It's incredibly important that we continue to fight for parity of esteem, and I think some of the funding that we're getting coming through now from the centre is helping us do that. But I think what we've got to continue to do is to build the partnerships with primary care, for example, to make sure that the sort of historical boundaries between primary care and secondary mental health begin to break down, and that we can continue to have the conversation and the dialogue around mental health being everybody's business. And I know these things are kind of cliches, but I really do feel as if there's been a bit of a shift over the last year in terms of people being open to talk about their well-being, partly in relation to COVID, actually, and partly in relation to how they've managed through lockdown, people who not necessarily had much contact with mental health services. So I think it's a bit of a mixed picture, but I think it's a good question. In terms of the CAP, so the CAP, the central access point, is a telephone, largely a telephone access, which I think has been really, really helpful for our service users. It's the first time that our system has had a self-referral through to a crisis service at any point, actually, but including crisis. Hitherto, if people were in a crisis, they effectively had to go through their GP and access crisis help through that. So I think that's been a very, very significant achievement. The mental health hub that you mentioned has been extremely well received by service users, and that effectively supports people who otherwise would have had to go to A&E to get some support, either referred directly by A&E or taken by EMAS and or 111. sent by 111, and they come to the Bradgate. So that's actually based at the Bradgate in what was our old outpatient centre. We reconfigured that very early in COVID. So that's where that is, and that's been tremendously supported by service users and carers who feel that it's extremely helpful, and it's been very helpful as part of our overall crisis pathway. And taken in context with the CAT, which is the self-referral, we think it's probably helped us hugely in terms of manage what we have to call flow, but what is really just, you know, people's needs at the right time, and how can we make sure people aren't queuing at A&E, queuing at or queuing at the Bradgate for beds, and I think that's been really helpful. And the last point, I don't know if Angela wants to address it, or I'm happy to, in terms of the challenges around the Bradgate estate and what we might want to do going forward.
Yes, I think obviously the Bradgate estate is a significant area, and I know we've talked about it before, and I know when I joined as Chief Exec, it was one where I was very clear that we needed to act and do something differently. Now, of course, the dormitory capital position is helping with that, and I really welcome that focus. Notwithstanding Councillor March's point around the beds, this is so important for our local population to eradicate dormitories. You know, I really feel very strong about that, and have campaigned nationally to get that position. So there is opportunity for us to do that, but obviously what we want to do is also make sure all of our accommodation is fit for purpose. And we are looking at outline cases so that we can strengthen not just the dormitory accommodation, but other facilities. But of course, that's all subject to money, and money is the wicked question, as Gordon said earlier, which is why, again, I need everybody on this call and in this meeting to be advocates for mental health, because the accommodation mental health needs to be as fit for purpose as any accommodation in the NHS. And I know that you would support me in that, but we will do everything we can to make sure that we can get capital monies in. And if we've got the local backing, then I'm confident that we will in due course get that. But we will also keep you updated in terms of any developments on that too.
Thank you. Well, hopefully that answers your questions.
Thank you, Chair. Thank you, Chair.
Great.
Yeah, thank you.
Okay, are there any other questions? Can I recommend that we note the report, but that we ask for continuing information along the lines of that has been raised by Councillors March, Sangster and Fonseca, and that the officers of the LPT pick up those points and keep that dialogue going. Is everybody happy with that approach? Yeah, that's agreed. Okay, so now we're on to item number 12. There's another presentation.
Yes, Chair, I'm really conscious of people's time. I know it's 10 to 9, and I'm just really conscious of that. So I just wonder if I may suggest, obviously we've got a paper in terms of the improvement journey. We've got a presentation, a set of slides that have been circulated. I would just take your steer and lead as to whether it's better to frame the discussion, get into a sense of any questions people may have, or whether you would prefer to do the presentation.
Now, are we happy to take the presentation as read? I've read the presentation. Do people want to get? Do you want to give a brief introduction, Angela, and then people?
Yes, of course.
Questions.
Thank you. And as I said, I've got Dr. Anne Scott with me, who is our lead director in our board around quality. So will give us the sort of sense of that improvement journey. But if I could just introduce, if I may, a couple of things. One is that I'm hoping the paper and the slides do give a sense of that journey to everybody. It's been a very much clear focus for the organisation, as you would expect. But a couple of things just to mention as well, because people may well say, well, what about a re-inspection? And what's the position in terms of the ratings in relation to LPT now? So I just wanted to frame that at the start. Very important for people to be aware that CQC are not inspecting services routinely at the moment. That's not something that's about LPT, it's about the national position in relation to COVID. But what they can do is inspect on a relation to risk. And that means they are doing surveillance and evidence and risk management on all of the NHS and all of the organisations that they inspect routinely. And what I can tell you is on that basis, they have not chosen to inspect LPT because they do not believe we are in that risk pool. That's very important for you to hear because that's significant to our local system and to us. And what's based around that is a series of relationships and evidence that we've been doing throughout the pandemic and throughout this improvement journey with them, giving them the materials. They've done staff focus groups, etc. So it is not based on us telling them it's okay. It's based on a series of facts, evidence and surveillance that has informed that decision. So I just wanted to say that, but also to say thank you publicly to our staff and our partners for supporting the improvement journey and for where we are today. So I'll leave Anne just to give you a sense of some of the highlights and then we'll take questions.
Okay, thank you very much, Angela, and thank you, Chair, and good evening, councillors. So I think the paper and the presentation, I hope, really does draw out certainly the first few slides in terms of the journey that we've been on, how we've strengthened the governance processes, how we've strengthened our strategy and our vision. And then further on in the presentation, there is really detailed description of the original findings, where I did sort of acknowledge at a health and overview scrutiny committee that we'd absolutely got it wrong. And I think, that the paper is now describing how we're getting it right. And that certainly is improving. The warning notice that we received of last year and the visit of the CQC when they visited in June of last year, in 2019, significant improvements were found. We've also identified where we were also needed to make further improvements, and I have detailed those in the report. And I've also detailed how we have address those improvements on our quality improvement journey. So I will pause there because Angela has already said around the inspection regime now for the CQC, which is what I was going to go into say, that our engagements meetings with the CQC are really positive. We've had some really, really positive feedback from the CQC recently in their focus groups, from their focus groups and in our engagement meetings. So it really is a very, very different picture now. And I'll pause there to take any questions. Thank you.
Has anybody got any questions? Again, my sincere apologies about the lateness of the point we've got into the agenda. I did say earlier on, I hope you can appreciate that given the items we had on, we did need to give them a significant amount of time, but unfortunately it does mean that you're on later on. And just as a broad thing, if you saw the journey from where you were to where you want to be, and again, I'm grossly simplifying it, but that may be grossly simple. What percentage do you think we've got there, and how long in terms of time before we get to where we want to be? A broad brush so we can get a feel for what progress has been made.
I mean, I can certainly comment. Angela may want to come in. I would say that we've made significant improvements actually, and I think we're in a very, very different. It's a very different organisation now, completely different. I think if you put me on the spot and you asked me to sort of do it in a percentage, we're well over 50% improved, well over. And I think certainly from the self-assessment work that we've done and the information, the intelligence that we're submitting to the CQC, we are rating ourselves as good in many areas now. It's a very, very different place, and our service users and our staff are telling us the same. So I think if you sort of pressured me on that, I would say definitely over 50%. I would say probably nearly 60%. In terms of time frame to get to sort of 100% to outstanding, I would like to say in the next 18 months, absolutely. I would like to anticipate that the next inspection that the CQC will rate us as good, and that's something that I don't say lightly, actually.
That's good. and so again, just broadly speaking, how far do you think COVID has and will continue to impact on that improvement process, or is it something that's run in parallel?
I think that's a really interesting question, actually, in terms of the impact of COVID. And one of the pieces of work that we're currently doing is really drilling down and identifying the impact that COVID has had. And what's really interesting is actually what COVID has done for us is started to release innovation. It started to release ideas, and real transformation has happened very quickly. So essentially things that probably would have taken years have taken weeks and months. So, I think that is quite significant. Angela wanted to come in, I think, yeah.
Yes, I think, Chair, if I may, I think it's really important to just focus briefly around the well-led position, because obviously, based on the discussions that have been earlier in the agenda as well, this is an important part of the position LPT was in. And of course, that well-led component not only relates to services, but is also around governance, risk, all of the elements that have been a feature for tonight's discussion. And it was something when I came in as Chief Exec that we have absolutely changed fundamentally. We have used our buddy trust in Northamptonshire, who are rated outstanding, and we have adopted, I believe, very robust governance arrangements that give us an ability to manage risk in a very dynamic way. I think the board has taken that and has run with it, quite frankly, and I will be very clear that the trust is in a very strong position around governance and risk, and that leadership leading other trusts actually, and would be able to support other trusts in that journey as well. So I think the well-led bit is important for you to hear because of the earlier discussions as well. Thank you.
Just to be, Councillor March, do you want to come in, please?
Oh, am I preventing you, Chair, from being just the devil's advocate there? Apologies if so.
I was going to ask a cheeky question, but I think you may beat us to the punch, please.
Maybe. Well, probably, likely. My question comes from skepticism around inspection regimes, really, and that I guess there is some from school inspection and sort of care home inspection. I guess that there's boxes to tick and things and criteria to meet, including well-led, and then I guess the paperwork and the evidencing of that is really important and clearly much more systematic than when things changed and after the last inspection. The dreadful one. And I guess though, on the ground, services, how do the two interact? So how does us aspiring to meet the framework impact on services on the ground if you're entering one of the mental health front doors or something that we're coming in about? And are we confident that that's where all of this work is really having an impact? Because that's the reason that any of us do any of it, right?
Yeah, absolutely. And I think most of the work that we do in terms of assessing ourselves and the peer review work that we have absolutely tests that. I think that's a really good point, and that's the ultimate test, isn't it? That we get it right for service users and we're getting it right for our staff. So absolutely, that they're the sort of the ultimate test of, and that's exactly what we look at is how does it feel, what is it that we're doing differently, and what does that look like? And also, we are really proud of the fact that from a patient involvement and engagement perspective, we've made significant improvements, and we have developed the People's Council, for example, which is a group of service users and carers and chaired by a Health Watch representative, Mark Farmer, and they are helping us on our journey as well in our quality improvement journey to make sure that we absolutely get the so what and the point, so that we don't miss the point, which is I think what you're saying. Yeah. Okay.
Thank you.
Yeah, I think the cheeky question I was going to ask is having been through it's for Angela more than anything, having been through, as it were, the ubiquitous journey on your governance procedures, would you ever go around for a cup of tea to have a chat to your colleague Rebecca Brown and have any lessons in that context from the challenges facing UHL? And similarly, calling right back to the innovation in terms of getting out the COVID vaccine. I note with interest Anne's thing about actually COVID sped up that innovation. And is that speeding up of innovation? It's a question for yourself, Angela, as well as Anne. Is that a lesson that can be taken forward about speeding up innovation in organisations? And let's be frank, we all love the NHS, but it can be quite rigid and hierarchical at times.
Yeah. No, thank you, Chair. And just to say, I mean, obviously Rebecca and Andy and I meet very regularly, weekly in fact, and so there is that natural exchange between us about anything any of us are doing to improve or to share issues, problem solve, etc. So we have very healthy relationships to be able to do that, which I think is what helps any learning culture. So we're always exchanging ideas about things that could work. So I think that's something we do. In terms of innovation, I think you make a really good point. I think COVID has given us, not us in LPT on our own, but across the NHS, across local authorities, an accelerator in terms of innovation, because we've had to be responsive, more responsive. We've had new issues that has created a climate through which innovation flourishes. We really welcome it. We're now locking in the benefits of it. But at the same time, we obviously wouldn't have wanted to have achieved it in the way that we have. So I think we've got to challenge to say, well, how do we create that climate without such challenging, very difficult situations? But I personally think innovation is very important for organisations, and organisations need to develop a risk appetite to support innovation. So it's something that I personally very much welcome.
And I was just going to say the same thing, absolutely. I think one of the things I would like to say is how proud I am of our staff actually, and how they've stepped up. And what we've really seen is talent has been released really quickly. And I'm really, really proud of the teams. All of them have worked tremendously hard, and not only to manage COVID, but to do the transformation required as well, and to not just manage COVID, but to really get through and keep people safe, keep themselves safe, keep our patients safe. And I absolutely couldn't be prouder of them all. I think it's COVID is really interesting. I think it's going to be really interesting to see some of the research that comes out post COVID around the lessons learned and what we're going to hold on to after COVID. So it's a really good question.
Okay. Thank you very much. Has any other members got any questions on this matter? No. Yeah. Well, thank you very much for the report. We will note the report with thanks and express our appreciation for you having stayed here to the end of the meeting. And we certainly look forward to further continuing updates, particularly if the CQC have any ongoing comments of note, if they can be communicated outside of the meeting cycle. And certainly it's encouraging to hear that I'm always highly impressed when a public servant gives us a timescale at 18 months, because I know that's an ambition. I know that's an ambition, but actually, I am always impressed by it, because believe you me, trying to get timescales again is sometimes a challenge. But I think the fact that you provided it shows that you've got focus, and whether you achieve it or you don't, you've got your eyes on the prize. So it's
absolutely
it's a good thing to hear. It's a good thing to hear. So thank you very much for your report. We look forward to further updates over the next 18 months. And again, if there's anything that is of interest to us that comes from the CQC, clearly their inspection regime is limited by COVID, then we'd quite happily hear it outside of the usual meeting cycle. Thank you again.
Thank you, Chair.
Thank you.
Okay, so that leaves us, I believe, with any other business. Is there any other business that we're aware of, Jason?
Sorry, Chair. No, I think there's the work programme just to look at from
Yeah,
Carol
sorry,
Brandon
the work
Cedar.
programme.
But no items of other business.
Okay. Has anybody else got anything to say on the work programme? It's just for noting. No.
Thank you.
If nobody has got anything else to say on the work programme, then I will declare this meeting closed. And thank you very much for your attendance. My apologies for the rather late running, but I think it was valuable discussion we've had this evening. Thank you very much.
Thank you, Chair.
Thank you. Cheers, everyone.
Thank you. Bye.
Good night. Good night.
Right.